The subcommittee will come to order. The chair recognizes himself for 5 minutes for an opening statement. The background and details of the topic of today's hearing are well known to physicians, to this subcommittee, and to most health policy analysts. The Sustainable Growth Rate, or SGR payment system, originated with the Balanced Budget Act of 1997. At that time, the intent of the SGR physician payment system, placing controls on Medicare spending through global spending targets and fee cuts if the targets were exceeded, seemed like a reasonable thing to do. However, within a short time, it became apparent that this policy was flawed. This subcommittee has had previous hearings that have addressed the shortcomings of SGR, including the repeated threats to patient access to care and provider income, and the mounting cost of congressional actions to override the scheduled fee cuts. Congress has acted to override these statutory cuts on at least 15 occasions, and the cost of these overrides has been staggering. The most recent one, the one-year extension override, comes at a price of $25.2 billion. Furthermore, all the money spent on avoiding cuts to physician fees has not gotten us any closer to a payment policy that will reimburse physicians for the value rather than the volume of services, will pay physicians and other providers fairly, and ensure access to high-quality health care for all Medicare beneficiaries. Today's hearing is an attempt to move us closer to that goal. This hearing will focus on three themes: data, measures, and models. In thinking about the proper payment policy, there seems to be fairly widespread agreement that certain elements are needed to build that system. First of all, physicians, payers, and other stakeholders need access to reliable data that can be used to improve the value of health care. Appropriate measures also need to be developed on an ongoing basis to continually assess progress in improving the system. In addition, as new and better payment and care delivery models are developed, they should be incorporated into the Medicare program. The witnesses that are here today are well equipped to address these areas. I would like to express my thanks to today's witnesses who have taken time out of their busy schedules to share their expertise with the subcommittee on this difficult problem, which has confronted the Medicare system for more than a decade. Now I would like to recognize the ranking member of the Subcommittee on Health, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Chairman Pitts. I want to commend you for holding today's hearing. As our first Health Subcommittee hearing of the 113th Congress, I think it sends a strong message that fixing the sustainable growth rate system is our top priority, and I certainly know it's certainly my top priority. So let me just note that I was very encouraged by Chairman Upton's remarks yesterday that it's his goal to put a bill on the House floor before the August recess. I stand ready to work with you both to meet that goal, and it's my hope that this will be a bipartisan process. But I'd be remiss if I didn't express my disappointment to see the release of a Republican framework by the committee and its Ways and Means counterpart. Truthfully, since I understand that there was a commitment to working with us on a bipartisan basis, putting out a Republican-only framework is somewhat perplexing. With little detail, I'll refrain from commenting on its substance, so I just ask that moving forward, any future products will include the input of the Democratic members of the committee. Now, we're here again racing yet another year of uncertainty in Medicare for physicians and beneficiaries. Clearly, we can all agree that the SGR is fundamentally flawed and is creating instability in the program. While the formula represented an attempt to minimize unnecessary growth in volume of services, it has not only failed to do that, but also fails to reward providers for improved quality and outcomes. As a result, Congress has spent more than a decade overriding arbitrary cuts to physician payments generated by this formula, with little to show for that other than an ever-growing budgetary hole. At a time when it's often difficult to find bipartisan consensus, this is one area where people on the left and the right of the political spectrum have come to agreement, and that is that the SGR formula must be repealed and replaced. But the question that has vexed those of us in Congress is how best to accomplish that replacement. While no one proposal is likely to hold the perfect solution, I believe there are a number of elements we should seek to incorporate into a new payment model, including building on the reforms that are already underway in Medicare through the Affordable Care Act. First, we have to reward quality. Providers who contribute to improved health care outcomes and better quality deserve recognition. Second, we must also reward efficiency, delivering the right care at the right time in the right setting. Third, we must reward collaboration and a patient-centered approach. Too often, Medicare is fragmented and a complete view of the patient is missing. We need to ensure providers have incentives to work together and share information. Now, today's hearing will delve into these issues by exploring how quality is measured, what data is needed, and what models will deliver the best results. These components must be resolved in order to finally replace the SGR. And so I welcome our witnesses here to bring their perspectives to help our members evaluate these essential issues. I also wanted to say, Mr. Chairman, I know, I don't know how many newer members we have today, but I do think my feeling is that the newer members of the committee on both sides of the aisle have a lot to offer with regard to the SGR and looking towards the future. And so I hope that we will get a lot of our newer members involved in whatever final outcome we come up with, because I do think they have a lot to offer. I want to close with a fact that I think can't be ignored, and that is that SGR repeal is too expensive to pay for with Medicare cuts alone, especially when Medicare cuts are being considered to reduce the nation's debt. I've said to many of my colleagues, including you, Mr. Chairman, that I really worry that every time there need to be some changes, you know, to meet the SGR goal or to deal with other health care initiatives, is always assumed that the cuts have to be within the health care system. And whether it's Medicare or Medicaid, we should not always look to provider cuts within the health care system to pay for other provider cuts that have been out there. I know we're all delighted to see that the cost of repealing the SGR is lower than it has been in years, but we're not fools. $183 billion is still a lot of money, and we simply can't find that amount of savings from Medicare alone. And that's why I've insisted from the beginning that we not only consider savings from within the healthcare system. I believe we can use another approach to write off the costs, such as an unpaid baseline adjustment or the OCO funds. The OCO funds is something I've suggested in the past. But in any case, the SGR is unstable, unreliable, and unfair, so the question remains, how do we fix it? I hope we can begin to truly answer that question after today's hearing so that we can provide security and reliability for our seniors and our doctors alike. I yield back. Thank you, Mr. Chairman.
Chair thanks the gentleman, and I join him in welcoming all the new members of the subcommittee, including on our side, Mr. Hall, Mr. Griffith, Ms. Elmers, and Mr. Bilirakis. At this time, Chair recognizes the chairman of the full committee, Mr. Upton, for 5 minutes for opening statement.
Thank you, Mr. Chairman. You know, by now we're all too familiar with how the current SGR system has caused uncertainty among physicians and threatened access to care for our nation's seniors. Unfortunately, the issue is ignored in the Affordable Care Act, but continuing to ignore it is no longer an option. Yesterday, I had the opportunity to address the AMA, and I emphasized our desire to work with physicians and the need for input from the medical professions in order to arrive at a physician payment policy that will, in fact, achieve real reform. Real reform will mean that doctors no longer have to wonder whether they'll face substantial fee cuts, and that our nation's seniors will not have to wonder whether they'll be able to see their docs. And during the last Congress, the Energy and Commerce Committee began a bipartisan effort to address the problem that has plagued seniors and their physicians for more than a decade. In 2011, the committee sent a bipartisan letter to more than 50 physician organizations soliciting input on how to reform the Medicare physician payment system. More than 24 responded with a good number of valuable ideas. This subcommittee then held hearings to address the issue, and the committee has continued to engage with physicians and other stakeholders to formulate a payment policy to solve this very difficult problem. Last week, Ways and Means Chairman Dave Camp, I, along with Subcommittee Chairman Pitts and Brady, and all, as well as other committee members, announced the release of a proposal to finally achieve long-term reform of the current SGR Medicare physician payment system. This is a top priority, and as we move closer to the goal, I'm confident that we indeed can make it a bipartisan effort. Today's hearing is yet another step in that way, and I would yield the balance of my time to the Vice Chair and a very important player as we've formulated the draft and pursue this issue, Dr. Burgess from Texas.
Well, I thank the Chairman for the recognition, and we all know that this sustainable growth rate formula it's an issue whose time has come and should have gone long ago. Its unrealistic assumptions of spending and efficiency certainly plagued this committee, but really the important thing is it's been a problem for doctors and it's been a real problem for beneficiaries at a time when beneficiaries are growing at 10,000 a day. It's already been mentioned about the framework where our two committees share jurisdiction. The framework does build off the work done over the past year and a half by the chairman of the subcommittee and his staff, and has involved collaboration from doctors and patient groups all over the country. It should be noted it's not for discriminating between physicians and other providers. It does not seek to benefit one form of medical practice over another. The framework realizes there are always going to be areas where providers choose or need to practice in a fee-for-service model. It doesn't mean there are not better ways to revamp fee-for-service, but it does mean that fee-for-service may continue to exist. Our goal cannot be flexibility in practice models if we do not have the ability to quickly evaluate innovative practice environments and, if appropriate, build them into future options. Innovation for the future is critical, and ever encouraging the reevaluation and adoption of models that adapt to changes in best practices and clinical guidelines and their technology. I'll submit the balance of my remarks for the record and yield time to Dr. Gingrey.
I thank Mr. Burgess for yielding. Mr. Chairman, I'm encouraged that Chairman Upton has signaled that SGR repeal and replacement will be a chief concern for the Energy and Commerce Committee this year. Excited to be here today, as it is hopefully the conclusion of a large fact-finding mission this subcommittee has undertaken over these past few years. We began with hearings to address the need for action, then to understand past attempts to reform, and now we are finally here today to seek how to use data and other measures to modernize and improve Medicare payment system as a last step before legislative action. As a doctor and as co-chairman of the GOP Doctors Caucus, I understand the necessity of these changes, and I look forward to seeing the job of reform completed this year. And certainly, Mr. Chairman, thank you for calling this hearing today, and I yield the balance of this time to the gentleman from Louisiana, Dr. Cassidy.
Thank you, Mr. Gingrey. The 113th Congress has a tremendous opportunity and obligation to finally eliminate the SGR payment regime. But I would say, as we discuss and contemplate new and innovative payment models, we have to keep in mind that the typical Washington solution involves very large bureaucracies, either public or private. That said, as a practicing physician, I know many of my colleagues are reluctant to give up their smaller practice. And if we're to achieve a quicker reform, we must keep that in mind, if for no other reason than that it is reportedly a major cause of physician burnout and early retirement. So my office is working on a proposal that would allow these physicians to continue to participate and gain in their private practice, but to have gain-sharing relationships, participate in those innovative reforms while retaining the independent nature of their current practice. And I would look forward to the Democratic side participating in this discussion as well, because I do think that is a bipartisan concern. I look forward to the panel's testimony and discussion, and I yield back. Thank you.
Chair, thanks, gentlemen. At this time, the chair recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. I guess that's called good timing. I was present at another subcommittee hearing upstairs, and I wanted to get down here as soon as I could. I want to thank you for holding this hearing. Today's discussion will focus on some of the critical questions we must address in redesigning Medicare's physician payment system. There's no question about it. Medicare is vital to the health of seniors in our country, and physicians are a vital part of Medicare and a critical partner to helping us build a health care system that provides better health care and improved health for all patients. We know that the payment system can drive patient outcomes, but unfortunately right now it is not driving it in the direction of better health and value. It's clear from this hearing that there is a broad consensus on the need to fix the problem, and even consensus on which direction we need to move. The question is how to get there. The Affordable Care Act provides the foundation for the right path forward. through its support for new delivery and payment models like accountable care organizations, bundled payments, medical homes, and initiatives that boost primary care, it moves us in the direction of improved quality, efficiency, and value. Innovative delivery and payment system models are also being developed and implemented by physician groups, health systems, regional health improvement collaboratives, and private payers, in some cases as private-public partnerships. We still hear more about these. We will hear more about these in today's hearing. We have the opportunity to leverage payment reform in Medicare to support these new delivery and payment models. We need to respect and encourage local innovation, but ensure accountability for improvement and prudent management. Our challenge is to judiciously balance the many competing interests in our healthcare system. I believe that we need to approach this discussion with physicians as our partners, but we also need to ensure that other healthcare stakeholders, including beneficiaries and non-physician providers, have input as well. It is no longer acceptable to accept the status quo. It is time for us to work together and permanently repeal SGR and put in place a truly sustainable system that aligns provider payments with quality and ensures that all Americans have access to the best care at lower cost. I'm pleased the chairman is moving forward with this hearing early in this Congress. I'm hopeful that we can find common ground on a solution for a problem that has been calling out for one for a very long time. We shouldn't have this SGR threat hanging over us every year with the uncertainty it has meant to the physicians in this country, not knowing whether Medicare is going to be there for them, which has brought about many physicians leaving the Medicare program completely, which is a disservice to the beneficiaries of Medicare. I thank you for the time allotted to me. I'll be happy to yield the short period of time I have left to any other member that wants me to yield. If not, I'll yield back the time.
All right. Chair thanks the gentleman. We have two panels today. Our first panel will have just one witness, Mr. Glenn Hackbarth, Chairman of the Medicare Payment Advisory Commission. We're happy to have you with us today, Mr. Hackbarth, and you're recognized for 5 minutes for an opening statement this time. Push the button on the... No, push.
Oh, there we go.
Okay.
Chairman Upton, Ranking Member Waxman, Subcommittee Chairman Pitts, and Ranking Member Florio. I appreciate the opportunity to talk to you today about repeal of the sustainable growth rate system for physicians. MedPAC, which I chair, first recommended repeal of SGR in 2001. We recommended repeal at that point because we thought that the system would be ineffective in achieving the goal of encouraging efficient use of limited resources, but also be inequitable to physicians, inasmuch as any penalties apply equally to all physicians without regard to their individual performance. To those two original concerns, we have now added a third, and that is that continuation of SGR poses an increasing risk to access to care for Medicare beneficiaries. Although we have not yet seen a significant erosion in access at the national level, we have all heard about problems with access to care for Medicare beneficiaries in particular markets, and especially for primary care services. MedPAC's fear is that those problems could spread rapidly if SGR is continued. We have a tight balance between supply and demand for services in many markets, again, in particular for primary care services. In growing physician frustration and anger about SGR means that even small numbers of physicians electing to reduce their participation in Medicare could have significant effects on access to care for Medicare beneficiaries. Now, to be clear, I'm not predicting a national crisis at this point, but we certainly cannot rule it out either. We have an especially good opportunity, I think, now to address the SGR issue. As you well know, CBO has recently significantly reduced the budget score attached to repeal of SGR. In effect, SGR repeal is now on sale, but the sale may not last forever. If experience is any guide, projections of this sort vary over time. I've been doing this for quite a while now, and I've gone through multiple cycles where we had low periods of growth followed by acceleration and rapid periods of growth, then low periods, and then rapid periods again. Right now, we're in a low period of growth in utilization of services, and hence the low score for repeal. I think it's important to seize this opportunity. Repealing SGR alone is not enough, however. MedPAC recommends that the repeal legislation pursue two other goals. First is to rebalance payments within the physician payment system, with particular focus on increasing payments for cognitive services relative to procedures and tests, with a particular emphasis on improving payment for primary care services. And the second objective is that we recommend is to encourage migration away from fee-for-service to new payment models for Medicare. The criticism of fee-for-service that one most often hears is that fee-for-service has the incentive to increase volume without regard to outcomes for patients. That's true. But from our perspective, equally important is that fee-for-service enables, if not encourages, a fragmentation of care delivery. And through its siloed nature, actually impedes the free flow of resources to where clinicians think they can do the best for patients. We believe that a better approach is a payment system that decentralizes decisions about what is appropriate care in exchange for accountability by clinician and provider organizations for outcome and total cost. Last point, moving to these new payment models will take time. These are complicated changes to make both on the payment side and on the care delivery side. They should take time. For us, that's a reason to begin now and not to delay any further. If we delay longer, it means that we will be well into the bulge of baby boomers retiring in the Medicare program, and the financial pressures will be heightened, and we believe as a result the risk to both physicians and patients will be greater. With that, Mr. Chairman, I'm happy to take your questions.
Thank you for your opening statement. Your entire written testimony will be made a part of the record. I will begin the questioning and recognize myself 5 minutes for that purpose. Mr. Hackbarth, in your testimony, you state that the array of new models for paying physicians and other health professionals is unlikely to change dramatically in the next few years. Yet, you advocate rewarding physicians as they shift their practices from open-ended fee-for-service to accountable care organizations. Are you suggesting that ACOs are the only models that physicians should shift to, or should physicians be able to choose how they practice from a wide variety of options?
A couple points, Mr. Chairman. First of all, we focus on ACOs because they are the new model that is already a part of the Medicare program. As you know, other models, medical homes, bundling around admissions, are being piloted at this point. ACOs, however, are the only model that are actually operational in the Medicare program. The second point I'd make is that the ACO model is by design a flexible model. It does not dictate a particular form of medical practice or a particular way for money to be distributed within the ACO among clinicians and other types of providers. And let me draw an analogy here. In the Medicare Advantage program, we have private insurers enrolling Medicare beneficiaries, and they deal with physicians in a lot of different types of practice. Some in solo practice, others in small groups, others in large multi-specialty groups. And they manage to deal with physicians in different settings, often with different payment models, depending on the particular location and type of practice. ACOs can have the same sort of flexibility. The principal difference being that ACOs, by design, are provider-governed organizations as opposed to organizations run by insurance companies. So we think that there's every possibility for the ACO structure to be a flexible one that does accommodate differences in practices and pay physicians in different ways depending on circumstances.
Now, you suggest that the fee schedule should be rebalanced to preserve access to primary care. And one way you suggest doing this is by giving a primary care bonus, similar to the provision in PPACA. However, according to the Association of American Medical Colleges Center for Workforce Studies, there will be 45,000 too few primary care physicians, but also a shortage of 46,000 surgeons and medical specialists in the next decade. If the goal is to increase the primary care workforce by making primary care more attractive to medical school graduates, do you think that a few years of modest payment increases will do this? And how does this address the projected shortage of specialists?
Yeah. So let me talk about the steps related to primary care first and then come back to other specialties. We actually think that there are a series of things that should be done to improve payment for primary care and increase the likelihood that more young physicians in training choose primary care as a career, and also that older physicians who are nearing retirement continue to practice primary care as opposed to elect early retirement. One step is to change how the relative value units are calculated in the physician fee schedule. And I'd be happy to go into detail on any of these if you wish. Second is to add new codes to the physician fee schedule to pay explicitly for activities that are now covered, like care coordination and management of transitions in care. A third is a bonus of the sort that you referred to in your question, Mr. Chairman. Fourth is moving to new payment models, as we are piloting with Medical Home, where part of the payment is on a lump sum per patient basis in addition to the fee-for-service payment. And then the last thing is graduate medical education. There is a lot of talk about a shortage of physicians, in particular a shortage of primary care physicians, and the need to increase the number of Medicare-funded GME slots. If Congress takes up that issue of expanding GME funding, we would urge it to look in particular at how those positions are distributed across specialty and assure that an adequate number are devoted to primary care. Now, on the issue of other specialties, we are not saying that primary care is the only specialty in which there may be supply issues, or certainly it's not the only specialty that matters to Medicare patients. All of the specialties play an important role in high quality care. We focus on primary care, however, because the evidence that we see that a robust system of primary care is especially important to a high-performing healthcare system. And so at a time of limited resources, we think that focus on primary care is justified based on system performance.
Chair, thanks, gentlemen, and now recognize the ranking member of the subcommittee, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I want to follow up on what you were discussing there with primary care. Mr. Hackbrough, just tell me what is the problem with primary care? In other words, what kinds of problems are we facing? Why are we facing this crisis? Just give me a little idea about how what we face and what's causing it.
Well, I think that there are several factors, Mr. Pallone. One is the overall level of compensation. As you well know, it is significantly lower than many of the subspecialties. In fact, if you look at it on an hourly basis under the physician fee schedule, the amount we pay for various specialty services is often 2 or 3 or more times what we pay for primary care services on an hourly basis. So there's a significant payment differential there. In talking to primary care physicians, though, I often hear that that's only a piece of the problem. Another problem is that fee-for-service as a method of payment is not really well suited to primary care because the fee schedule doesn't recognize all of the activities that make primary care important for the care delivery system: education of patients and ongoing contact with patients, coordination of care, and the like. And often, in these days where we've got a relative shortage of primary care, the practices are frankly overwhelmed with the work they need to do and the number of patients they need to see. It's important, therefore, to help primary care practices build some of the infrastructure that would allow them to better manage larger volumes of patients. And that's where the lump sum payment in the medical home is particularly important. It allows practices to hire additional staff to work with patients on some of the educational activities, allows them to build necessary systems and the like. So we need to make the job more doable as well as increase the average compensation level.
All right, thanks. I wanted to ask about physicians who don't fit in delivery models. As you know, there's a great deal of diversity in the healthcare system and various specialties and practice patterns, different kinds of markets, some dominated by hospitals, some more dominated by a plurality of provider groups or individual practitioners. How do you design a reformed Medicare payment system that works for all physicians? And how do we address the measurement challenges for a myriad of physicians? Are we always going to have some doctors that don't fit in a delivery model, or are we always going to have doctors for whom the quality measurement system just doesn't work? How should we deal with this, essentially?
Well, we may, at the end, have some physicians that are in unique circumstances, for example, very isolated areas that we will have to treat as a special case. But as I indicated in my response to Chairman Pitts, ideas like the Accountable Care Organization, I don't see as rigid models that dictate a particular form of physician practice. ACOs, as defined in the statute and in the regulations, are able to accommodate different styles of medical practice, solo practice, group practice, and the like. And in fact, if we look around the country in terms of how practices deal with managed care organizations, again, private insurance plans, you see a lot of variety. So take a state like California, where you've got a lot of managed care activity and have for years. Some of the physician practices there are large multi-specialty groups. But there are also independent practice associations where much smaller practices are hooked together with one another for purposes of contracting, sharing resources, and the like, and sharing financial responsibility. So I think that there are opportunities for many different styles of practice. It's not a one-style-fits-all model in the ACO.
Can I just ask, time is limited now, but I think Medicare needs to make more data available for development of models and care improvement. What's MedPAC's view of CMS's current data policies, and is there some way that the agency and Congress can encourage a more data availability?
Yeah. Well, I don't consider myself expert, Mr. Pallone, on the CMS data systems. Traditionally, it has been a struggle for CMS to provide timely data, for example, to physicians, and in the pilots in the prepaid group practice demonstration project. In part, at least, that's a function of resources. The agency, in our judgment, has been chronically underfunded. The tasks that it has to carry out are increasingly complicated, including on the data front, and they don't get the resources they need to do those jobs well. And I think we're paying a price. You know, it reduces the appropriation side of the budget, but the lack of robust data means that we're going to spend more on the entitlement side of the budget.
Thank you. Thank you, Mr. Chairman.
Chair thanks the gentleman, and now recognize the Vice Chairman of the Subcommittee, Dr. Burgess, for 5 minutes for questions.
I thank the Chairman for the recognition. Mr. Akbar, it's so good to have you back at the committee. You know, the downside of solving the SGR is we won't get to have these visits every couple of years, but I'll actually look forward to that as well. Maybe we'll both find something better to do with our time. Could you speak, we were just talking to Mr. Pallone about models. Could you speak for just a minute about what you have learned from the study of Medicare Advantage programs? Some, I understand, have worked well, even with the constraints of the SGR. Others maybe not so well. So are there positives that we can take away from the Medicare Advantage experience?
There are positives. In fact, some Medicare Advantage plans, as you know, perform extremely well on both quality of care measures and cost. And among the plans that perform well, there are a variety of different models. You know, some of them are the prepaid group practice model, like Kaiser Permanente, but there are other plans that contract with individual independent practices and don't rest entirely on large multi-specialty groups.
Well, and I would just offer an observation that it's not just the satisfaction of the agencies and the people who measure those things, but it's also satisfaction of patients and satisfactions of physicians. And certainly my experience with a group like Scott and White down in Temple, Texas, is this has worked reasonably well, and maybe something that we certainly want to be careful that we don't damage whatever we do going forward. Can you speak to, you know, everyone this morning is kind of focused on the fact that, hey, the CBO put SGR on sale, so let's buy this week while it's low. Could you talk just a little bit about why it's low, and is there a dark side to it being low right now?
Yeah, and there are a number of reasons, and understanding all of the magic of this CBO estimation process is not one of my strengths, and so
me neither.
Detailed accounting you ought to get directly from CBO. But the most important factor is that the rate of growth in Medicare expenditures, in particular physician services, has slowed significantly in the last several years.
Yeah, let's stay on that for just a minute. Why is that? Is that because of the recession? Is that because of physician ownership of some facilities? Where could you drill down on that a little bit?
Well, the short answer is I don't think any of us really knows. As you well know, there's been some speculation about the effect of the recession, although logically you would think that that would be less of a factor for the Medicare population, which by definition had continuous coverage through the recession. There's been some sort of public health factors, you know, a relatively small flu season in recent years has held down utilization. We've seen a significant slowing of the rate of increase in imaging. That could be due in part to changes in payment, but also due in part to growing concerns about radiation exposure. And finally, it could be that some physicians believe the world is changing and are preparing for a new world where total cost of care is more important.
Yeah, have the new methods of payment been around long enough for them to stake any legitimate claim in these savings?
You know, I think the jury is out on that.
I think so. The answer is no. The short answer.
Yeah.
Okay, I'll accept that. But let me just ask you this. I mean, you talked a little bit about decentralization, and I must admit, we've had these discussions before. You hit a nerve with me. It's not decentralization, it's re-centralization. I mean, you take the authority away from me as a practicing physician, and you're giving it to someone else. It's not that it's gone away and magically just been dissipated out into the ether. So it's not decentralization, it's re-centralization, and you know, I think a lot of physician groups and certainly patient groups fear that re-centralization will occur somewhere, whether it's in an insurance company, whether it's in a hospital, whether it's in the government itself, where their interests may not be served. I mean, let's remember, an accountable care organization begs the question, accountable to whom? And if the doctor is employed by the hospital, if the doctor is employed by the government or an insurance company, then they're probably accountable to their employer, are they not?
Yeah. Well, I know there is widespread, although not universal, concern among physicians about having to work for the hospital in an ACO. But in fact, 50% of the ACOs that have been approved and signed contracts with CMS have been physician-sponsored organizations, which, as a former CEO of a physician group, I consider to be a very positive sign. I happen to believe that physician-sponsored organizations are the way to go. And so I don't think the ACO model is synonymous with hospital control. My fear about fee-for-service is that continuation of fee-for-service combined with the inevitable increase in fiscal pressure from the retirement of the baby boom generation inevitably leads to ratcheting down on the rules around fee-for-service payment. More intrusion from central locations like Washington and Baltimore into clinical decision-making, more detailed rules about what you have to do to qualify for this type of payment and what you're not allowed to do if you qualify for that kind of payment.
So we both have the same
away
concern about re-centralization then.
Yeah, but I believe that the ACO model can push those decisions out where they belong, in the hands of clinicians. Now, the quid pro quo is that the clinician organization assume accountability for overall quality of care in costs for the defined population. I think that's a good trade for clinicians.
Thank you, Mr. Chair. We can go on about this for quite some time, but I appreciate your indulgence.
Thanks, gentlemen. And now recognize the gentleman from Michigan, Mr. Dingell, for 5 minutes for questions.
Mr. Chairman, you are most courteous. I commend you and the committee for this hearing. This is something which very much needs to be addressed. And I'd like to welcome our witness. The point of this question is, how do we balance quality measure development to ensure physicians have a voice in the fixing of fees and so forth, but also see to it that we have broad enough participation by the public at large in these matters. Now, physicians are, as we all know, essential partners in improving quality and accountability. At the same time, there's challenging questions that need to be answered regarding their appropriate role. So when it comes to performance measurement, especially as it will be used to drive new payment systems, don't we have to have a broad participation by physicians, by patients, by hospitals, and by the other people in the provider chain? Is that right or wrong?
I think, Mr.
Just
Dingell,
yes or no?
I think...
Yes or no?
Yes or no? I think it deserves a more robust response.
Well, we need broad participation, don't we? I have limited time, and I need your cooperation.
I do, in general, favor broader participation, but I really would like the opportunity to...
So everybody ought to have a say, right?
Pardon me, I'm sorry.
Everybody ought to have a say. The doctors ought to have a say. Their say is going to be very important. Hospitals, patients, insurers, the whole works. They all ought to have a say. We ought not rig this device so it favors one particular participant over others.
I think we want a system that does three things. It brings scientific evidence to bear on what the appropriate standards are.
One of the problems I have is I get witnesses down there, and they just feel they got to make speech. And all I'm really asking for is a yes or no. How many folks do we want in this? Do we want enough that we get a clear picture and we get an honest answer? Or do we want to have just one group doing it and skewing the result?
I think that we need a range of participants. I think we need a range of participants. But the objective...
Thank you. Now, what is the appropriate role, then, of physicians in developing performance measurement systems, and how do we ensure appropriate multi-stakeholder process, including, again, consumers, purchasers, and providers, that avoids conflicts of interest and gets us the best possible picture? Now you make speech.
The role of physicians is to help bring scientific evidence to bear on establishment of standards. But that's not the only step in the process. To have appropriate standards, we also...
Am I being somewhat unclear? I'm just trying to get you to tell me how we set this process up so we get the answers that is best suited to saving us money, getting full service, seeing to it that everybody participates. How do we do this?
And that's what I'm trying to answer, Mr. Dingle. If it were easy, and clear, it would have already been done, sir.
My time.
I'm sorry?
Now, let's go to the next question and hope we have the time to do it. Where are the opportunities to reduce unnecessary care, save wasted dollars, and improve the value in the current FFS while we're transitioning to new payment models? You have 1 minute and 20 seconds.
There are a number of areas where
Please
there are...
make haste. You have 1 minute and 10 seconds.
There are a number of areas where we can reduce waste and excess utilization. It's a long list, not suited to 1 minute and 10 seconds.
Would you like to tell us what they are? And relieve us of the need to speculate?
One would be, for example, readmissions, excess readmissions, avoidable readmissions to the hospital.
What
Another would
some
be,
of the others?
every time I try to answer, I'm interrupted.
You've not
Another would be excess.
Make speed. You have 22 seconds.
Another would be excess imaging that not only is costly, but poses a risk for patients due to radiation exposure. So those would be two examples. I'm trying to stay within your limits, sir.
My time is exhausted, Mr. Chairman. I thank you for your courtesy.
Chair thanks the gentleman. Now recognize the gentleman, Mr. Hall, for 5 minutes for questions.
Thank you, Mr. Chairman. I'm a little confused. This is the same John Dingle I learned to ask questions and extract answers from. Hadn't let up at all. Age hadn't bothered him nor lessened his pursuit. And
I thank my old friend.
And I'm a little concerned because I was on this committee for, I think, almost 30 years. 2 years ago, I took a leave of absence. And I find the problem exactly the same almost as it was when I left. And you, Mr. Hackbarth, you said it right when you said we're at a critical juncture for SGR reform. And you pointed out the recent CBO lowered the cost of repeal by over $100 billion. That ought to help some. And you added an dimension of the problem that every time the pay cut's delayed, the size of the cuts the following year is bigger. So it's 2 years bigger from the time I left to this day when I'm back. Let me ask you a question that affects my part of the country some. The current SGR formula based part of its reimbursement on the time it takes to perform a task. And do you believe that this has created the right incentives for beneficiary care, or do you believe that a shift away from time and more toward paying for quality would be more appropriate for the delivery of beneficiary care?
We do believe that we need over time to shift away from a fee-for-service system to other payment models that focus on quality and value for patients. However, the fee-for-service system is likely to be with us for still some time. And one of the problems that we see in the existing physician fee schedule is that these time estimates that you refer to, we think are often off by a significant amount, and that affects the distribution of payments within the fee schedule.
Yeah, we're not lacking for suggestions, and even Heritage pitched in saying we ought to allow price flexibility among specialties, remove the cap on how much a doctor can charge, enforce price transparency, allow private contracting, and on and on. But we're here today, and I guess there are a number of physicians that are reporting requirements currently in statute. As part of the reform, do you think some sort of streamlining of such reporting, similar to what Mr. Dingle was questioning about, is absolutely necessary to develop the kind of performance measures that you touched on in your testimony?
Mm-hmm. Yeah, we do think that measures of performance, in particular measures of quality, are an indispensable part of both the existing fee-for-service system and any new payment models. And I do have some ideas about what such a system should look like to formulate those measures. As I started to say in response to Mr. Dingle, I think it should include scientific input. Specialty societies have a major role to play there. But our measures also ought to be carefully chosen to increase value for Medicare beneficiaries. Not anything that's good to do should be rewarded with a bonus payment.
And I'm impressed by the quality of this committee, of those that you've selected, Mr. Chairman, and I'll yield back my time.
Chair thanks the gentleman, and now recognize the gentlelady from California, Ms. Capps, for 5 minutes for questions.
I want to thank all of our witnesses, both panelists, for being here today, and thank you, Chairman Pitts and Ranking Member Pallone, for holding this very important hearing. I've long been a supporter of fixing the SGR. It harms providers and consumers alike, and it keeps us from true innovation in the healthcare sector. But the conversation often stops at the crisis point, how to make it to the next paycheck, and rarely moves to one where we can discuss our vision for a healthcare system in the future and how to get there. That's why I'm so pleased that we're having this forward-looking hearing today. There has been a lot of talk about the role of doctors in the healthcare system. But as I've said before, in some respects I'm following on to our distinguished former chairman, I truly believe that if we're going to really move to a more comprehensive, prevention-focused system of care, we need to look at the full picture of our healthcare system. Mr. Hackbarth, most of the new delivery models like patient-centered medical homes and accountable care organizations emphasize team-based care, and they recognize the critical role and value of non-physician providers. As such, I think it is important to acknowledge the role of other healthcare providers such as nurses, nurse practitioners, physician's assistants in this conversation as well. While physicians and physician payment has always received a lot of attention, and rightly so, it is important that non-physician providers are also actively engaged in both the development and the implementation of these new systems for healthcare delivery and payment. So I have a couple questions on this topic for you. First, why do you think there is such a disparity, gap, between the importance of non-physician providers and the level of attention they are receiving in the SGR debate?
Well, I'm not sure why there is that disparity in attention.
I mean, do you acknowledge that it does exist?
I agree it does exist. And I also agree with your statement that we're not going to get where we want to go in terms of improved healthcare delivery without an expanded role for other health professionals, including advanced practice nurses and physician assistants.
Right.
And the like.
So there's no reason that it's just lack of attention?
I think it is lack of attention and, sort of history in terms of how our healthcare system has evolved. But, when I look at the growing problems that we have in primary care,
yeah.
I just don't see how that's going to be solved without expanded use of other health professionals.
Well, and you're representing MedPAC, which is a group of people. Has this not come up in your discussions? What is your view on the role of non-physician providers in a new value-based delivery and payment system that's focused on outcomes rather than fee-for-service?
It comes up often, I assure you, and I think I speak for the Commission as a whole in saying that we think that an expanded role for nurses and other health professionals is essential, both to deal with short-term problems like access to primary care, but also for long-term improved system performance.
Do you, just in your own structure, because you're a spokesperson for MedPAC, do you see yourself expanding the commission members, or how is your discussion?
Well, in fact, over the years, almost always, we've had one or more nurses. Currently, Mary Naylor from the University of Pennsylvania School of Nursing is a member of MedPAC and has been very helpful in talking about the role of nurses, for example, in transition care after a hospital admission transitions to the community.
That's just one of the many roles that they can play. But this is, one could say that this is a little bit like a token representative. Do you have any discussion of ways to expand it to be more inclusive?
Well, we actually don't choose our own members. Under the statute that governs MedPAC, GAO actually appoints the membership of the commission.
Do you listen to other organizations, accountable care kind of organizations? And maybe this is just a vacuum that needs now to be addressed.
Yeah, we do. For example, another member of our commission is Scott Armstrong, the CEO of Group Health of Puget Sound in Seattle.
Okay.
An organization which for many years has made a very extensive use of advanced practice nurses and other non-physician health professionals in team care. That perspective comes into our discussions, not just through people who have RN after their name, but also from other commissioners that deal with these systems, that lead these systems.
Well, my time is up, but I do want to tell you that as a nurse myself, I guess I'm a little bit more sensitive to the fact that nurse organizations, and I'm sure physicians' assistants would be the same, are eager. They have been doing a great deal of discussion among themselves and ascertaining of patterns that they would like to see in an expanded role for how to reach the goals of accountability. We're really talking about how to reach the goals of the Affordable Care Act. And reimbursement, the fee schedule, is one of those, and of course it's clearly a very important aspect of how that is functioning. So I would urge you to reach out, and we'll try to establish more communication so that this can be a more serious part of your agenda.
I'd welcome that.
Chair, thanks, gentlelady, and now recognize the gentleman from Illinois, Mr. Shimkus, for 5 minutes for questions.
Thank you, Mr. Chairman, and welcome, Mr. Hackworth. I kind of been interesting the intensity of this first line of questioning. I appreciate the work you do. It's very difficult, so thank you. I'm trying to pull up the website and the like. Understand that you have on March 7th through 8th you have an open public meeting at the Ronald Reagan Building in the International Trade Center. I imagine that's where you take comments and from anyone who may be involved. So all these groups, all these individuals that are involved with that, isn't that kind of why you do that?
Well, yes, we have open meetings, but we don't stop there. We reach out to groups that we think have expertise, information to bring to bear on the topics before us. So we don't wait for them to come to us. We look for them.
Thank you. To help Mr. Dingell, I can think of one way to help address costs is that's litigation reform, medical liability issues. I'm from the state of Illinois. If you know from Illinois, you know the medical liability crisis that we continue to have with high costs. So there's enough, I would consider that low-hanging fruit to help address the cost of bringing down the cost of care. So we could go through, as you said, there's numerous, and it would take longer than a 5-minute round of questions. But there was also a comment, that Mr. Dingell mentioned that, we do want to make sure a lot of folks are inclusive in these discussions. That's why I focus to the open meetings aspect. But sometimes there's a feeling that the beneficiary is kind of left out in some of these dollars and cents, care, procedures, and debate. So my couple questions that I'm going to do direct kind of focus on the beneficiary. And so do you believe that it's important for the overall success of reform efforts to find ways to incentivize the individual beneficiary along the way?
Yes, we do believe that is a part of what needs to be done.
So if we have new models of care that were developed that involve sharing savings between beneficiaries and government, should the beneficiary share in those savings as well?
In our comment letters on the development of the ACO program, we recommended that, in fact, beneficiaries have the opportunity to share in any savings. Seems to us odd that all of the focus should be on how the government and providers are going to share and the beneficiary is left out of it.
Yes, it's just, and I've been on the committee a long time also, and it's great to have Mr. Hall back because maybe we'll get this solved now since he's been gone for a while. Now he's back, and maybe we'll get this solved with his expertise. But I'm still a capitalist competitive model, folks. I do think people shop around based upon dollars and cents, and based upon their return on dollars, they'll make decisions. I also believe the public will buy a premium quality if they're given the opportunity to. My frustration with the healthcare delivery system is they're kind of left out. I mean, they're not incentivized, they're directed, there's no variability and choices, so that I'm happy to see that. On the other hand, I believe there are some negative incentives within the Medicare program that might hurt beneficiaries and endanger reform, like a catastrophic cap within Medicare, co-pays that are based upon percentages instead of fixed costs, so beneficiaries know that they are what they are liable for, and first dollar coverage that incentivizes beneficiaries to use more services when the new models encourage providers to be more efficient with the care provided. How important is it for the success of reform that Congress address these issues?
Well, about a year ago, Mr. Shimkus, we made a series of recommendations related to reforming the Medicare benefit package, and you touched on some of the critical elements. We think that the current structure is antiquated and very difficult for Medicare beneficiaries to understand. And so we recommended that it be simplified, use fixed dollar co-pays as opposed to percentage co-insurance, which is unpredictable, include catastrophic coverage. We also recommended that the Secretary be given broader authority to introduce principles of value-based insurance design, by which we mean the Secretary should be able to say, the evidence is really strong that if patients have access to this service, it not only improves their health, but it lowers long-run cost. And so we may want to totally eliminate cost sharing for those really high-value services. On the other hand, there are services that are of lower value based on scientific evidence, and we may wish to impose more cost sharing on those. This is an idea that's being used increasingly by private insurers, and we think it makes sense for Medicare as well.
Thank you very much. Thank you, Mr. Chairman.
Chair thanks the gentleman, and now recognizes the gentleman from Texas, Mr. Green, for 5 minutes for questions.
Thank you, Mr. Chairman, and again, Ms. Hackberg, welcome. Appreciate your work over the years. The sustainable growth rate formula is broken and must be repealed and replaced with a system that pays doctors fairly for their services and ensures that the quality coverage for seniors and reduces the financial burden on taxpayers. One of the ways I want to, and I understand a lot of folks do, want to achieve cost savings is through the quality improvements. There's a bipartisan agreement on this issue broadly, but there are disagreements on specifics. I want to work toward a bipartisan agreement on measuring quality to increase efficiency and quality of care while decreasing the cost. We owe it to our seniors today and the future generation of seniors to make good on that promise we made for affordable quality health care through Medicare. So I'm going to try and go through a number of questions quickly. What's the most effective quality improvement measures with respect to improving health outcomes?
Well, I'd say the single most important thing is to move to new forms of payment in care delivery, where clinicians accept ultimate accountability for outcomes that matter to patients, but also the associated financial responsibility. As I said in response to Dr. Burgess, we think decentralizing decisions to clinicians and provider organizations with increased accountability is the most important thing to do.
Okay. What criteria must be met to realize savings from the quality improvement initiatives?
What criteria must be met? Could you just say a little bit more?
What criteria must be met to realize savings from this quality improvement initiatives?
Yeah. Well, the most important criteria is that, of course, we want to protect beneficiary access to care and quality of care, and that's why having accountability for outcomes is really an important part of the system. But while doing that, as I said earlier, what we want to do is not make decisions here in Washington, but have clinicians who know the patient, who know local circumstances, have increased decision-making authority.
Okay. Is a voluntary adoption of these quality improvements sufficient to yield system-wide savings, or does this need to be a required practice? And I know your questions earlier, your answers rather, were that there are some private insurance who are already doing some of this.
Yeah. We think that a wise course for Medicare would be to apply increasing pressure on the fee-for-service system, which for the reasons I described at the outset, we fear is not consistent with quality for Medicare beneficiaries. Apply pressure on fee-for-service and then create incentives and opportunities for people to move into new care delivery models that can deliver higher value.
Okay. And what is the best way to address the quality improvement when programs serve such a wide variety of people with various health needs? For example, seniors who have disabilities, and as we know, as we get senior, we're going to take a lot more health care than someone who's not, but also low-income earners.
Yeah, well, having a robust system of adjusting payments to reflect the underlying health risk of the patients is really important. We don't want a system where providers avoid those complicated patients because they're not paid appropriately for them. If a provider assumes responsibility for complicated patients, they ought to get the associated resources to do the job well. So that what we refer to as risk adjustment is a really important feature.
Okay. In developing quality measures, there's quite correctly been a lot of focus on including physicians and physician groups in the discussion, perhaps even having them develop the measures for their own specialties. And I would hope that would be, the input from our specialty societies. What other entities should be at the table specifically? Shouldn't the beneficiary somehow be represented in some capacity?
Yes, as I said in response to Mr. Dingell, we think that the physician specialty societies can provide critical input, but input from others is important as well, including from patient organizations.
Okay. My last question in 35 seconds is, I know seniors are worried about changing the SGR and could result their care being diminished, and this is a scary prospect. But I also want, and I think a lot of us share bipartisan, you want to make sure this system's around for my children and my grandkids. What's the best way to ensure that the SGR is repealed and replaced, that the beneficiaries will have a seat at the table and the changes are made a positive experience for them?
So the question is, how do we assure that this is a positive experience for Medicare beneficiaries?
So they know that they're going to be able to have the Medicare that they could traditionally feel comfortable with.
Well, we need to take the necessary steps on payment to assure the system is fiscally stable, but we also need to offer choices to Medicare beneficiaries. As I said in response to Mr. Shimkus, having patient choices, but also choices that reflect the cost of different options is important.
Thank you, Mr. Chairman.
Chair, thanks, gentlemen. I recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes for questions.
Hey, Ms. Hackbarth, I'll be more polite than Mr. Dingell, but if you could keep your answers concise, I'd appreciate it.
I will try.
I understand that, and I think you're doing a fantastic job. Listen, I think there's evidence that consolidation is actually driving up cost. If you look at how hospitals are buying physician services, is this a premonition of what is to come?
We do worry about a hospital-dominated system. As I said to Dr. Burgess, this is one of the reasons why I think having physician-sponsored organizations is very important.
I could also see, though, that physician-sponsored Pioneer ACO being purchased by a large hospital. And so it almost seems like if you're really good at it, you may get bought. Let me ask you, some of this diminution in or decrease in the amount of care being delivered through Medicare Part B, I've been able to figure it out. How much of that is attributable to hospitals purchasing, say, cardiology practices, now billing through Part A as opposed to Part B?
Some of it is.
And when you say some, is that 1% or is that 30%?
Well, let's focus on one area where it's a fairly significant factor, the rate of growth in expenditures on imaging services.
Now, did those previously go through B or through A?
When they were provided in independent practices,
that's through B.
Cardiology imaging in particular was in Part B. When it moves over to the hospital practices by...
So really, we may not see, so this just may not be something on sale. It may be part of a larger trend where consolidation is shifting cost to A.
There could be some of that, yes.
But then that in turn will further stress the Medicare Trust Fund.
Yeah, although if we look at total Medicare expenditures, the growth there is slowed as well.
Now,
it's not just on Part B.
I think statistics show about 25% of Medicare beneficiaries don't have a primary place they go. and the ACO relies upon some sort of retrospective kind of statistical analysis. You belong there even though you got your liver transplant here. Now, Mr. Miller will give testimony suggesting that prospective assignment would be a much more efficient way, better way to approach this as opposed to the retrospective assignment that occurs with the ACO model under statute.
And we favor prospective.
Now that leads us to MA. It really seems as if MA kind of solves this, even though there's a prejudice in the administration against MA.
Well, as I said earlier, there are some similarities between the two, but a critical difference is that by definition, the accountable care organizations are controlled by providers as opposed to by insurance companies.
Now, we both know of models, you know of models. There's the WellMed model down in Texas in which they go at two-sided risk with the Medicare Advantage program, but effectively being a two-sided risk, they are now managing. Yep. Would you favor such models?
So you're referring to a model where there's a partnership between an insurer and...
I think now they've purchased them, but at some point the physician primary care group would contract with whichever MA plan they contracted with at 85% of what the MA plan was getting from CMS.
Yeah.
And they in turn would be a two-sided risk relative to the MA plan.
Yeah, there are a lot of different varieties that can work, and as I've tried to emphasize, we think that that's a good thing because the circumstances really differ in places around the country. There are different preferences.
Now let me ask, because again, my concern, as I said in my testimony, is that our bias is towards big. And an ACO has to have a minimum of 5,000 patients. That means inherently it is big. So to what extent can that solo practitioner, how can she survive without being absorbed?
Well, 5,000 patients isn't all that large. You know, that's several internal medicine practices have 5,000 patients. Well, actually, if it's 5,000 Medicare patients, it would have to be, you know, a somewhat larger number. But they don't all have to be under one roof and common ownership.
But there will be a
models you can link.
But to get the economy of scale in terms of marketing, in terms of billing, in terms of data integration, that suggests that you're going to have a certain bigness, correct?
Well, there is no doubt some scale required. But again, those costs can be shared and spread over a larger number of practices.
Now, what do you think about an IPA model that would contract with an MA-type entity where there'd be prospective assignment, and yet you get the advantage of the MA data analysis, et cetera, but nonetheless allow these folks to maintain their autonomy?
You know, it is an entirely legitimate approach that's worked in a lot of areas. But you could also have an ACO that contracts with an MA plan just to provide support services and, you know, to buy reinsurance and spread risk. But the provider still
my concern about that is that when you start doing statistical analysis, that small little practice won't really know whether that outlier, that 25% of patients who's going elsewhere, are they getting a square deal from the top dogs or are they not? You see what I'm saying?
Well, and in fact, that's the problem when you have small practices and small numbers. As you well know, there's a lot of statistical variation, about random variation in the numbers, and that makes assessment more difficult. And that's one of the reasons that linking practices together and getting larger populations makes sense.
Hey, you've given great answers. Again, I thank you for your courtesy, and I yield back.
Chair, thanks to gentlemen. Excellent line of questioning. The chair now recognizes the gentlelady from Florida, Ms. Castor, for 5 minutes for question.
Well, thank you, Mr. Chairman. Thank you for calling this hearing. Mr. Hackberth, welcome. You know, since coming to Congress, I have to say one of the most nonsensical policies that we deal with is how we patch SGR and treat Medicare physicians, and the patching and discussions that go on every year. It's remarkable. It's not reasonable, and colleagues, we've got to do something about it finally. And it should not be lost on us what this recent CBO score is. It is. You said it's like it's on sale now. The CBO score has dropped $107 billion from 243 to $138 billion. Now is the time to act, to solve it, to repeal it, to replace it with something that makes better sense for the modern health system, especially with the Affordable Care Act. I concur with Ranking Member Pallone that it's too important for us to just haphazardly steal from other Medicare providers to patch over here. And because of this renewed score that's over $100 billion lower, we have the ability now to really take a hard look and solve this now, and time is of the essence. I also supported going to the OCO. I thought that was quite reasonable, and now I don't even think this would take up what is left in OCO savings. So we have an opportunity here in the coming months, and we should not let it pass. But we have larger issues as well, and I think that moving forward, solutions on replacing the SGR with different payment models, I think in Dr. Berenson's testimony, he laid out, you're never going to get away entirely from fee-for-service. There will be some medical services that's how they'll have to be compensated, and the difficulty will be carving those out as we move to different integrated models and pay models. So, Mr. Hackworth, I think by this time everyone agrees that we need to move the delivery system away from fee-for-service or something blended toward integrated delivery systems. That is, systems where physicians work together and share responsibility for their patients. While the Centers for Medicare and Medicaid Services has already embarked on a significant testing of these models, how do we incentivize more physicians to join these models and take
well,
risk?
we think it needs to be a combination of two things. Some steadily increasing pressure on fee-for-service that frankly makes staying in fee-for-service increasingly uncomfortable over time, while we open the door to new payment models and provide an incentive for physicians to participate in those models. So it's a little bit of push and a little bit of pull.
And I understand that the popular view is that models like accountable care organizations, the medical home, and bundled payments have the potential to save Medicare money and improve patient outcomes. But first, do we really know yet whether they will be successful or what forms of these models will work best? And second, in the absence of ironclad answers and evidence, how do you recommend we proceed encouraging physicians to embrace new models?
Yeah. Well, ACOs are now an operational piece of the Medicare program, whereas the bundling around hospital admissions and medical home are still in the pilot phase, and we're still collecting information. The reason that ACOs were put into the operational mainstream Medicare program at this point is that, in fact, we had done a demonstration, a group practice demonstration, testing basically the ACO-type model. And to make a long story short, that demonstration showed some promise for this model to improve quality while somewhat reducing costs in some cases. The results were not overwhelmingly robust, but they were generally positive. In making a policy judgment about this, we need to always say, well, what is the alternative? It's our judgment that the results on ACO were sufficiently strong that when compared to continuing fee-for-service, we thought moving towards ACOs made sense. We know the record of fee-for-service. We've done the 35, 40-year experiment with that. High cost, uneven quality. And so that's a pretty low standard to beat, and we think ACOs can comfortably do that.
Thank you very much. I go back.
Chair thanks the gentlelady. Now I recognize the gentleman from Virginia, Mr. Griffith. 5 minutes for questions.
Thank you, Mr. Chairman. I do appreciate that. Mr. Hackbarth, you encourage physicians to switch from open-ended fee-for-service to accountable care organizations. Do you envision a continued role for FFS in certain geographic locales? I know you've already talked about certain practice types, but coming from a district that takes a long time to get from one end to the other and has lots of small rural communities, do you anticipate that fee-for-service would still be the way to do it there, or do you think that they can do an ACO with such a small number of folks?
Well, we're still early in the development of the ACO model, but I would note that about 20% of the ACOs that have been approved to this point include community health centers, rural health clinics, or critical access hospitals. So there's at least some development in rural areas of ACOs. And we'll have to see over time, how well that works and how many more develop. So I wouldn't completely write off the possibility right now that the ACO model, which is a very flexible one, can work in rural areas. There may, at the end of some period of time, be some really isolated geographic areas with very long distances where that model simply will not work, and we'll need to take special steps in those areas.
Or mountains in the way.
Or mountains in the way.
Yeah, because that happens a lot of times.
Mountain area, yeah.
It happens in my district from time to time. And I heard you in one of the other questions, and I apologize, that the ACO would need 5,000 patients?
Yes, that's the minimum. And the reason for that is, again, to have numbers that are statistically meaningful and not full of just random variation.
All right. And I also would ask, even with the progressive payment models, such as the bundled payments, what is there that would prevent a delivery system from exploiting a volume-based approach with bundled payments? I mean, can't they still do unnecessary things and run their costs or up and overcharge?
Yes, and that is one of the fears. So if we bundle payment around an episode, hospital admission, for example, one of the fears is, well, now that you've aligned physicians, hospitals, and other actors, they'll say, well, let's increase the number of episodes. Let's increase the number of admissions. And so that is something to monitor and be careful about. That's less of an issue in ACOs where there's accountability for total cost, not just episode cost.
I thank you very much and yield back my time, Mr. Chair.
Chair, thanks, gentlemen. Now recognize the gentleman from Maryland, Mr. Sarbanes, 5 minutes for question.
Thank you, Mr. Chairman. Thank you, Mr. Hackbarth. So, as I understand the SGR formula, basically a number of years ago, there was a kind of projected percentage increase in payments that we were prepared to pay. And in the early years, we just went ahead and paid it even if it exceeded what that trajectory was supposed to be. But the trade-off was that at some point we had to come back and recover it. And that started to kick in the out years. And that's what happened. That's the fire drill that we have every year. So fixing SGR is really getting rid of SGR. I mean, SGR is it's a design for trying to keep the costs, in a sense, after the fact, in line with this original trajectory that was established.
That's correct.
Right. So all of these other issues about, rebalancing payments and looking at the methodology and, whether we adjust the relative value units or add codes that better address the needs of primary care and so forth. That discussion can kind of happen alongside of the decision that's being made to get rid of this design.
Right. Even if we get rid of SGR, we need to have that conversation, yes.
So just anticipating the kind of legislation that we would need to pass here, it could be pretty simple, right? I mean, could it be basically a one-page bill saying the SGR system is hereby repealed, and then these other discussions, which frankly have been initiated through the Affordable Care Act in large measure, can proceed? Or do you feel that sort of you don't want to lose the moment of casting aside SGR to also embed statutorily some of these new goals that you want to see?
Yeah, we think it's important to seize the moment of SGR repeal to do three things. One, get rid of SGR. Two, to advance progress in rebalancing the payments, as I said in my opening statement. And third is to create incentives for physicians to move towards new payment models. And if the legislation simply repealed SGR, we think that would be a lost opportunity. Frankly, these other two steps of rebalancing payments and encouraging movement to new payment systems, there will be some people who will oppose those.
Well, so that's kind of my question is, if we're starting to get tied in knots over doing these other things, such that that begins to impede the opportunity to just get rid of the design, where would you come down then?
Yeah, well, our expertise is not on, legislative process and tactics, but we believe that there ought to be this quid pro quo. Mm-hmm. Physicians want to get rid of SGR.
Okay, so that's fair. So you're saying SGR was designed as a kind of cost containment measure. So if we're going to get rid of one cost containment measure, let's replace it with other things that we think are going to help us achieve the same goals. Okay, I understand. I understand that. That makes a lot of sense. I'll just say in closing, then I'll yield back. I mean, I'm not a physician, but I spent 18 years representing hospitals and physician groups. And for some period of time in which I was practicing, I managed this fire drill on behalf of clients that was happening at the end of every year. In a sense, we've been fixing SGR every year, right? Or every 30 days or every 90 days or whatever it is. So it's not like not fixing it means we're not going to incur the cost, because we're probably going to come back, do a fire drill, patch it, incur the cost. So when we talk about taking advantage of this sale, I mean, it's versus running around on the back end and trying to do it. It's really the equivalent in the healthcare arena, and with respect to physician payment, it's like a sequester thing. It's an arbitrary formula for just slashing.
Yeah, you're absolutely right that what we've done is fix it a year at a time, or unfortunately, in some cases, a few months at a time. The price we pay for that is that we're undermining the confidence of both physicians and patients in the Medicare system. We're destabilizing the system. And our fear is that the cumulative effect of these last-minute dramas is now really taking a toll on confidence in Medicare and increasing the risk that Medicare beneficiaries will lose access to needed care. It's time to do away with it.
Chair thanks the gentleman and now recognizes the gentleman from Georgia, Dr. Gangry, for 5 minutes for questions.
Mr. Chairman, thank you. Mr. Hackbarth, you just mentioned that in the responding to Mr. Sarbanes' line of questioning that three things that are important. One, repeal SGR, rebalancing payments, I think, was the second, and then developing new payment models. And indeed, that's what the hearing is all about. And of course, we'll have a second panel. We appreciate your testimony and response to our questions. But I think there's a fourth thing here that you might put in the category, the 800-pound gorilla in the room, and that is iPad, which is the iPad creation under the Affordable Care Act. Now, you, as I understand it, have been head of the Independent Payment Advisory Commission ever since its existence, and on a yearly basis or twice a year advise, and we have the ability under this system to mitigate recommended cuts, and we've done that, and that's where we are today, just as Mr. Sarbanes was saying, and I think that if we do these three things, if we repeal SGR, if we rebalance payments, and if we develop new payment models that physicians have the ability to choose from, and slowly but surely, hopefully, they would do that. But if the Independent Payment Advisory Board is still there in the law, what good is all this going to do unless we get rid of that I'm going to say monster, because it seems like to me it really is a monster, because it's not advisory. It's instructional. So would you touch on that a little bit and tell us?
Well, as you indicated, Dr. Gingrey, our model, the one that I've participated in, is advisory, and the ultimate decisions are up to you and your colleagues in the Congress. And we hope that works well for you. We work very hard to do our best to advise you on those issues. With regard to IPAB specifically, we haven't taken a position one way or another on IPAB. It's sort of a rival approach to dealing with this, and we thought that was more a matter for the Congress to decide, and not really a matter of Medicare policy where we consider ourselves to have some expertise. So right from the outset, we've not taken a position either for or against IPAB. We see.
Well, let me just interrupt you just for a second and say that this member of the committee, this physician member of the Energy and Commerce Health Subcommittee, feels that it would be better to continue your commission in an advisory capacity and all that institutional knowledge that you've gained over the last 10 years and get rid of the monster that gives us no ability. Indeed, I think it's really unconstitutional to say that Congress doesn't have the ability to mitigate as we do under the good advice that you give us. Mr. Chairman, the power of the IPAB, we all know, is substantial. Even if the President continues to delay in naming members to the board, I don't guess there are any members named so far. 15 is what it's called for. The secretary, this secretary, the next secretary of HHS would have the power to establish these cuts. And as we were saying, you read that real carefully, that IPAB section of the Affordable Care Act. Up until 2020, hospitals would be excluded from any cuts. So the proposed cuts made by IPAB would fall particularly on providers during, the next 10 years almost. And to me, this seems akin to the cuts that SGR has tried to impose on doctors. These types of cuts haven't worked in SGR, and they surely won't work with IPAB. I'm encouraged that the committee's proposed framework states that IPAB repeal would be an integral part of SGR reform. So, I think that needs to be an important part of the discussion with you, Mr. Hackbarth, and also with the second panel. My time's expired, and I yield back, and I thank you for your response.
Chair thanks, gentlemen, and now recognizes the gentlelady, Dr. Christensen, for 5 minutes for questions.
Thank you, Mr. Chairman, and I thank you and the ranking member for this hearing, because I hope, and welcome again, Mr. Hackbarth, because I hope that this year we can finally fix it all, something that all of us agree needs to be fixed and want to fix. As we know, the SGR has been the wrong methodology for setting physician reimbursement, because it doesn't reflect the market basket value of physician services today. And as you said, the uncertainty that we create every year just transfers that uncertainty to the Medicare beneficiaries, who wonder whether they're ever going to get the services that they need. In addition to creating the new ways of reimbursement, I think it's important, as one of the AMA reports says, to establish an accurate definition of healthcare value, rebuild the technological infrastructure, determine episode length, payment attribution, improve data and other parameters. And as a physician who practiced in a fee-for-service model, just for the record, I really don't believe that fee-for-service in and of itself was the problem. It's the way it was. We were incentivized, and I can't say that I was, but to utilize certain modalities that were expensive, and we weren't paid for other things that you're talking about paying for now. And I believe if we pay for that kind of management, and now with CER and PCORI and other provisions of the ACA, fee-for-service can possibly have a place. But lastly, as Dr. Patel said last year in her testimony, whatever you do, the path needs to be toward clinician-driven, which you've agreed and said many times here this morning, evidence-based medicine that preserves the autonomy of the physician-patient relationship, even as we move towards more accountability. You can imagine what my questions were going to veer towards. My colleague, Mr. Green, sort of asked it because we talked about poor minority communities and patients who are affected by many of the social determinants of health and lack of access to quality health care and some services not even available in their area. And so they suffer poor outcomes. So you did say that we have to take that into account and set the baseline and look at, include that in the way we measure performance. But I was wondering if the minority health profession schools, minority health profession organizations, patient advocacy organizations, are they involved in providing input to as we move forward, do you know?
Yeah, well, we work with all of the associations, both within the physician world and beyond. Spend a lot of time with representatives of safety net institutions, which are, as you well know, critically important for this population. And so, absolutely, our door is open. We think paying particular attention to those patients, and many of them in Medicare dual eligible for Medicaid as well as Medicare. They're some of the most vulnerable patients in the system. And so we need to take particular care when we develop new models that they're not inadvertently harmed.
And you did mention in responding to Mr. Green also the issue of adverse selection and cherry picking.
Yes.
And do you see the possibility of setting some kind of incentive payments for taking care of patients that may be sicker and coming from areas with high health disparities?
Absolutely. So we think that the payment to the organization ought to be commensurate with the responsibility that they're taking on. And if you're taking on very high risk, complicated patients, you ought to be appropriately compensated for that. This is an issue in the still developing demonstrations run dual eligibles. Again, one of our most vulnerable populations. And so it's one we're fixated on. We'll have all sorts of bad consequences if we don't pay a lot of attention to that.
Right, and I'm glad that under PCORI they're really looking at social determinants, they're looking at health disparities, and that we were able to include in a lot of the research and provisions of the Affordable Care Act that health equity and eliminating health disparities had to be one of the goals. Thank you, Mr. Chairman. I yield back.
Chair, thanks to the gentlelady, and now recognize the gentlelady from North Carolina, Mrs. Elmers, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Mr. Hackbarth, for being with us today. I've been a nurse for over 20 years, and obviously very concerned about the SGR system and understand fully that it is broken. Physician practices, hang on to those determinations of when we're going to get paid, when we're not. And obviously the breakdown is quality of care for the patients and the accessibility moving forward. So keeping those thoughts in mind, I am a little concerned. I know Mr. Dingle and my colleague Dr. Christensen was just talking about some of the patient advocacy groups and patient input. Of course, we want healthcare to be patient-centered. But when we're talking about standard of practice, clinical practices and standard of care, where do you weight patient satisfaction, so to speak? I know that this is going to be part of this system, but are we weighting the satisfaction level of quality, and determining quality of care that way?
Yeah, within the ACO system, patient satisfaction is one of the criteria used in evaluating performance. And we think that plays a role. Frankly, we don't think it should be given the same weight as outcomes of care the patients really care about.
So you would say, on a percentage basis, what would you say, how much are you going to be taking that into consideration?
Yeah, I'm not sure that I'm, off the top of my head, I could tell you exactly what percentage ought to be given to patient satisfaction. But ultimately, patients go to their physician and nurses because they have a medical problem that they want fixed. Mm-hmm. And so the bulk of the focus should be on, are those problems fixed? Mm-hmm. And if the patient, in addition to that, has a good experience, that's important as well. Probably the element of patient satisfaction that I would say is most important is effective communication. Mm-hmm. Because that also has implications for things like adherence to, sure, drug regimens and adherence to follow-up care after hospital admissions and the like. Mm-hmm. I'm less interested in putting a lot of weight on, sort of the hotel experience, what was the check-in and the like. I'm not saying those are totally unimportant, but less important to me than effective communication and outcomes.
I also do, and this is a little bit off of the focus here with this particular question, but I am a little concerned too when we're talking about reimbursement and the more emphasis on different practices and improvements. And you mentioned the cutbacks in imagery services. Can you give me 2 reasons why we would consider that to actually be cutting back on reimbursement to imagery?
Well, one of the things that we do is look at how accurate the level of payment is for individual services in the fee schedule. And as we've looked at that work and done that work, what we've concluded is that in many instances, we are overpaying for imaging services.
Is it overpaying, or are you concerned that imagery is being overused?
Well, it's some of each, and the two are linked. Okay. So we believe that for some imaging services, not necessarily all of them, but some imaging services, the payment for each service is too high. And it's therefore a very profitable service that prompts people to go out and buy expensive imaging equipment. Then once the imaging equipment is in place, it is used because it's inexpensive at that point. And that results in overutilization of services.
Well, one thing I would like to get there again, based on my experience, one of those areas too that I think needs to be considered is not so much that the imagery is being overused but maybe ordered more frequently by non-physician practitioners. We in our local area, of course, JCO has just come through, and basically one of their determinations where there were too many tests being ordered, and unfortunately that is by your non-physician practitioner. And I think that's an issue that needs to be looked at much more effectively, because we want the best care for our patients ultimately, but at the same time, if it's just a matter of overutilization, then I think that needs to be looked at much more closely. Yeah,
well, I think that may well be an issue. But, we look at the rates of imaging, and there's huge variation. And so if you look geographically, you see big differences in both rates of imaging and the frequency of re-imaging of the same patient. Mm-hmm. And so it's data that we look at that suggests to us that there is a problem here.
Thank you. Again, I think efficiency is one of the areas that we really need to be looking at. So thank you. I yield back the remainder of my time.
Chair, thanks, gentlelady. Now I recognize the gentleman from New York, Mr. Engel, 5 minutes for questions.
Thank you very much, Mr. Chairman. There's no question that the sustainable growth rate formula is seriously flawed and needs to be permanently replaced. I very strongly believe that physicians deserve to be fairly and appropriately compensated for the important work they do, and the current SGR formula is failing our physicians and it's failing our Medicare beneficiaries. I'm pleased that the new CBO score estimates that it will cost dramatically less to repeal the scheduled SGR cuts and freeze payment rates for the next 10 years. I know the cost of $138 billion will be difficult to overcome, but now is the time to permanently fix the way we reimburse physicians for the care they provide to our Medicare beneficiaries. The cost of doing so will probably never be lower. So as a Congress, I really believe we must seize the opportunity. Let me ask you a couple of questions. In MedPAC's October 2011 letter to the chairman and ranking members of committees with jurisdiction over health care, it was stated, and I quote, "The greatest threat to health care access over the next decade is concentrated in primary care services." That's unquote. Recognizing primary care access is critical, as part of the Affordable Care Act, Medicare started paying primary care physicians a 10% incentive payment in 2011. It's my understanding that more than 156,000 primary care providers have benefited from these incentive programs. So my question is, does MedPAC intend to analyze the impact of this 10% incentive payment on beneficiary access to primary care? If so, when do you think it will be possible to gauge this particular incentive's impact on Medicare beneficiary access to primary care services?
I'm not sure if that's on our near-term analytic agenda. I think it might be a pretty difficult piece of analysis to do. But what I'd ask Mr. Engel is let me talk to my colleagues about it and get back to you on that.
Okay, thank you. MedPAC's reports and recommendations have consistently recommended moving toward payment models that shift providers away from fee-for-service and its incentives driving greater volume and intensity of services to delivery models that reward quality and efficiency. The Affordable Care Act has a number of provisions supporting new models of care, including accountable care organizations, or ACOs, and value-based purchasing. How do we know if these new models are moving our delivery and payment system in the right direction? I believe they are, but how do we really know?
Yeah. Well, in the case of ACOs, as I said earlier, that was put into the Medicare program without further demonstration or pilots because there had been a demonstration done known as the group practice demo. The short version of that is that there were some positive but not really robust, strong improvements in that demo, but the results were deemed good enough that it made sense to move forward with ACOs. My own belief is that over time, with more experience, ACOs will be able to improve performance even more than happened in the group practice demo. Value-based purchasing has also been evaluated, and there too the results were not really robust. There was a demonstration done involving hospital value-based purchasing, known as the Premier demo, and the short version of the story there is that there may have been some positive results, but the effects were not very strong. And some of the same effects were accomplished by just feeding back information on quality without a payment attached to it.
All right, thank you. Let me ask you this. Several of our witnesses in written testimony mentioned the imperative for more data if Medicare is going to successfully move from a fee-for-service reimbursement system to more quality-driven models. So what are some of the steps you would recommend CMS and HHS take to ensure our health information technology infrastructure is capturing the right data to provide adequate reimbursement for quality health care services?
Yeah, well, I am not at all expert, Mr. Engel, on health IT, so I can't answer in any detailed way. But I do believe that as more and more healthcare organizations adopt computerized medical records, that can greatly expand our capacity for assessing performance, because we'll have ready access to clinical information, not just claims-based information, but clinical information about how well patients are faring in different organizations. So this is a very important investment the country is making. I'm optimistic that it'll pay off in the long run. But as I think you know, getting to that point is an arduous journey.
Yes, thank you, Mr. Chairman.
Chair, thanks, gentlemen. That concludes. No, we still have one more. I'm sorry. The gentleman from New Jersey, Mr. Lance, recognized for 5 minutes for questions.
Thank you, Mr. Chairman, and I will not take the full 5 minutes. I apologize for not being here. I was in the Commerce Subcommittee all morning. One question. One of the common responses to the letter that our committee sent out to physician groups was that they need a period of stable payments, and I don't think anybody disagrees with that. However, if we simply stabilize payments, we may not get movement to the kind of payment system we need. In your view, how might we incentivize physicians to move away from what they are currently doing and toward a payment system based on value and not just the volume of their service?
Yeah, we take a bit different view on this. It's not been a pretty process with lots of sort of last-minute rescue efforts, but there has been considerable stability in payments in recent years. Again, not the right way to accomplish
with great angst.
Great angst, and the angst has caused problems, which I emphasized before you came in, Mr. Lance. And so, I'm not advocating what's happened, far from it. We think that if we're going to really accelerate movement to new payment systems, there needs to be some pressure on fee-for-service. Now, exactly how much, how quickly, is in part a function of how much money there is in the system after you figure out the pay-fors for SGR repeal. So there's not a right answer to how to structure that, but we do think we need a combination of pressure on fee-for-service and then new opportunities and new payment models.
Thank you very much, Mr. Chairman. I yield back the balance of my time. Yes, sir. Thank you.
Chair, thanks, gentlemen. That concludes the first panel. Excellent testimony. Very thoughtful answers. Thank you, Mr. Hackbarth. We will excuse panel 1, call panel 2 to the witness stand, and I will introduce the second panel as they come. First of all, I want to thank all of you for agreeing to testify before the subcommittee today and quickly introduce our second expert panel. First, Mr. Howard Miller, Executive Director of the Center for Healthcare Quality and Payment Reform. Secondly, Ms. Elizabeth Mitchell, CEO of Maine Health Management Coalition. Thirdly, Dr. Robert Berenson, Institute Fellow at the Urban Institute. And finally, Dr. Cheryl Damberg, Senior Policy Researcher and Professor at the Pardee Rand Graduate School. Again, thank you all for coming. We have your prepared statements, which we entered into the record. And Mr. Miller, we will begin with you. You're recognized 5 minutes to summarize your testimony.
Thank you, Mr. Chairman. It's a pleasure to be here today. You have what may seem like an impossible task to repeal the SGR program and save money for the Medicare program and do that without harming patients or physicians. But I believe that you can do that because of 4 key facts. First fact is that there are tremendous opportunities to save tens of billions of dollars in the Medicare program by helping prevent avoidable admissions to the hospital, readmissions, and to reduce the incredible rate of infections, complications, and other kinds of problems that occur to patients. Medical errors exist today. There's no need to deny beneficiary services or to cut fees in order to reduce spending. Second fact is that the current fee-for-service system actually makes it difficult for physicians to help Medicare take advantage of those savings opportunities. In fact, under fee-for-service, the most desirable outcome of all, which is keeping you healthy, doesn't get paid for at all. Third fact is that you can't fix fee-for-service simply by adding more pay-for-performance bonuses or penalties or creating shared savings programs. Many current payment reform efforts, I think, will have limited success because they leave the current broken fee-for-service system in place. In particular, they force physicians to lose money when they help Medicare reduce spending. The fourth fact is that there are better ways of paying physicians that give them the flexibility to both improve patient care and reduce Medicare spending without having to take financial losses themselves. I've outlined these in my testimony, and there are reports available on our website that describe these in significant detail. What I wanted to focus on is how to actually get these accountable payment models in place. I believe that more is needed than the traditional top-down approach where CMS develops all new payment models. Because the specific opportunities and barriers differ from community to community, and because different physicians will have different levels of willingness and ability to participate, many different solutions will be needed. Most payment models today are focused on primary care, hospitals, and large ACOs, but we need to also give every physician specialty the opportunity to improve care and reduce costs within its own sphere of influence. To do this, I recommend that Congress also establish a bottom-up approach, whereby physicians, provider organizations, medical specialty societies, and regional multi-stakeholder collaboratives are invited to develop payment models that will work well for individual physician specialties and the realities of their own communities. If any of these groups brings CMS a payment model that is specifically designed to improve patient care and save Medicare money, CMS should not only have the power, but the obligation to approve it. CMS should then also make that same payment model available to any physician who wants to participate and has the capabilities to do so. Moreover, if a physician is participating in such a model, they shouldn't be subject to threats of SGR-type payment reductions. This kind of bottom-up approach is not as radical as it might seem. The CMS Innovation Center has been doing something just like this for the past 2 years through programs such as the Innovation Awards and the Bundled Payments for Care Improvement Initiative. But I think there are 5 policies that Congress needs to establish if you're going to have a truly successful process for developing and implementing new payment models as quickly as possible. The first policy is that new payment models should be able to be proposed to CMS at any time, and there should be no limit on how many different proposals can be approved as long as they improve care and save Medicare money. Proposals also need to be reviewed quickly, and as I mentioned, CMS should have the obligation to approve a proposal if it improves patient care and saves Medicare money. The second policy is that there should be frequent opportunities for physicians to apply to participate in the already approved payment models. Every physician should be permitted to participate in an approved accountable payment model whenever they are ready to do so. The third policy, physicians need to be given access to Medicare claims data so that they can actually determine where the opportunities for savings are, how care will need to be redesigned to achieve those savings, and how payment will need to change to support better care at a lower cost. I can't even begin to describe to you what a barrier it is to moving forward on this because of the lack of information that physicians have available to them. Fourth policy, once a physician is participating in an accountable payment model, they should have the ability to continue participating as long as they wish to do so if the data show that the quality of care is high and Medicare spending is being controlled. Most innovative payment models today are explicitly time limited, and no physician or other healthcare provider is going to make significant changes in the way care is delivered if they might be forced to revert to the traditional fee-for-service system within a few years. We need to stop doing demonstration projects and start implementing broad-based payment reforms. Fifth policy, funding should be made available to medical specialty societies and multi-stakeholder regional health improvement collaboratives so that they can provide technical assistance to physicians. Most physicians don't have either the time or the training to determine whether and how a new payment model will work for them. If organizations that they trust, though, can help them analyze data and redesign the way they deliver care, I think physicians are far more likely to both embrace new payment models and to be successful in implementing them. Finally, I must note that I think the payment reforms will be much easier to implement and far more successful if you also take steps to proactively involve the patients, the beneficiaries. Many of the existing payment models are forced to use complicated statistical attribution methodologies to determine which physicians are accountable for which patients. It would make far more sense to simply ask the beneficiaries to designate which physicians they want to be in charge of each of their conditions. I'd be happy to answer questions that you may have.
Thank you, Mr. Miller. Ms. Mitchell, you're recognized for 5 minutes for your opening statement. Please poke the button there on the mic.
Thank you, Mr. Chairman and members of the committee. My name is Elizabeth Mitchell. I'm the CEO of the Maine Health Management Coalition, and I want to start by thanking you for taking on this issue. As I'm sure you well know, employers and state governments can no longer afford cost increases. Our employees can't go further years without wage increases, and our providers are increasingly burdened in a system that does not reward high performance and creates daily barriers to improving care for patients, largely due to current payment systems and a lack of data. Thank you also for hearing from a Regional Health Improvement Collaborative. We are an employer-led multi-stakeholder collaborative based in Maine. We've been around for 20 years, and we include employers from the state employees to LL Bean to the Medicaid program, large multi-specialty groups, academic medical centers, and primary care physicians. We work together in a partnership to improve quality and reduce costs. Maine has been very successful in addressing quality. We have some of the best healthcare quality in the country. We know that our efforts in data sharing, measurement, and public reporting have been key to achieving those gains. However, despite these achievements, quality and safety failings continue. And more discouraging is that the quality improvements have not reduced the cost of care for purchasers and patients. Cost and quality vary by region, as do opportunities for improvement. Maine is the birthplace of the Dartmouth Atlas, where Dr. John Wenberg first observed vast differences in maternity care within Maine, with no correlation to demographics, patient acuity, or patient preference. He also noted that his kids would have received vastly different treatment for their tonsillitis if they lived one county away. Variation in cost is even more pronounced. Just as there is no single problem facing healthcare, there is no single one-size-fits-all national solution. I believe with adequate data and support, regions are well positioned to not only identify but help solve their own problems. Data is necessary to identify regional improvement opportunities and to engage stakeholders in improvement. The Dartmouth Atlas would never have been possible without good data. But data is necessary but insufficient. Once opportunities are identified, stakeholders, particularly physicians, must be actively engaged to change current practice. We must now be equally effective using data to engage physicians, purchasers, and patients in care improvement. Data is essential for many, many reasons. Identifying priority cost and quality improvement opportunities, enabling performance measurement and public reporting, establishing cost and quality performance targets, informing choice by consumers, engaging physicians, and managing population health. The premise of medical homes and ACOs is better management of population health, but it is both unreasonable and unfair to ask physicians to assume risk without adequate, timely data. States and communities face different challenges, and physicians need local, timely data to direct their work. To direct physicians to focus improvement efforts on non-priority areas is a sure way to frustrate them when they are not even paid for this improvement work. But they know where care can be improved, if you ask. Significant savings are also possible through readmission reduction, through improved C-section rates. There are opportunities around the country if you have the right data to target them. You rightly recognize the central role of measurement in both improvement and accountability. A key barrier to addressing costs in ways that were equally successful to addressing quality is the lack of nationally endorsed cost measures. Without measures endorsed by the National Quality Forum, we found it impossible to reach consensus on relevant metrics. Regardless of the payment system, appropriate and transparent measurement is required to understand how patients fare in new models. Good outcome and patient experience measures will also support more flexible payment models. New models and incentives to reduce costs must be balanced by ongoing measurement. You reference physician-endorsed measures, but we would urge you to consider multi-stakeholder endorsed measures. As those who pay for and receive care, purchaser and patient voice are crucial to identifying the right performance indicators together with physicians. Whether measurement or population health management, none of this work is possible without data. Unfortunately, multi-payer data is very hard to obtain. Many health plans consider it proprietary. Many provider-run data organizations are reluctant to share it publicly. But as Dr. David Howes, the president of Martins Point Healthcare, summed up our challenge, the age of competing for market share by controlling access to data is over. Transparent, all-payer data should be made widely available, and competition should be based solely on performance. Medicare's Qualified Entity Program is an important step toward giving communities and providers the information they need to improve care. The Qualified Entity Program is a strong signal of partnership and support for local innovation and an endorsement for use of integrated data. CMS should not only continue to enable qualified groups to share data, but you should accelerate it with financial support and greater flexibility. Regional health improvement collaboratives are stewards of multi-payer data and experienced leaders using the data for improvement. We may be your innovation infrastructure and partners for implementation on the ground.
Thank you, Ms. Mitchell. Dr. Berenson, you recognize 5 minutes to summarize your testimony.
Thank you, Chairman Pitts, Mr. Pallone, and members of the committee. I very much appreciate the opportunity to provide testimony as the committee attempts to identify how to achieve higher value of physician services for Medicare beneficiaries and taxpayers. It is a subject that I have been deeply involved with through most of my professional career as a practicing general internist, practicing just a few blocks from here for over a decade, a medical director in managed care plans, a senior official at CMS, and vice chair of MedPAC until this past May. As an Institute Fellow at the Urban Institute, I am currently involved in a project to improve how services in the Medicare fee schedule are valued for payment. While there is broad agreement on the need to move from volume-based to value-based payment, the current emphasis assumes that measuring a few quality measures and somehow attributing costs generated by many providers to an individual physician can produce accurate estimates of a physician's value. Measurement is more difficult than some policymakers assume, while the evidence on pay-for-performance for hospitals, frankly, is not encouraging. For physicians, behavioral economics suggests that pay-for-performance can crowd out professionals' intrinsic motivation to help their patients and can actually worsen performance. What has been lost in equating value-based payment with pay-for-performance is the recognition that value can be fostered not only by improving how well particular services are performed, but also by improving the kind and mix of services beneficiaries receive. The Medicare fee schedule for physicians and other health professionals produces too many technically oriented services, including imaging, tests, and procedures, and not enough patient-clinician interaction to diagnose accurately, to develop treatment approaches consistent with a patient's values and preferences, and continuing engagement to assure implementation of a mutually agreed-upon treatment plan. Nor does the fee schedule emphasize care coordination and other patient-centered activities that would actually improve patient outcomes. However, the price distortions that plague the current fee schedule are not inevitable. Even in fee-for-service, Medicare can buy a better mix of services by altering the prices paid for services, balancing considerations of beneficiary access to care with reducing overuse of services caused, at least in part, by inordinately high payments for some services. We can improve the fee schedule over the short term, even if the ultimate goal is to reduce its importance or eliminate it altogether. In fact, in my view, it is necessary to improve the fee schedule to be able to successfully implement new payment models. First, the migration to new payment approaches will take years. Even then, fee-for-service may be part of new payment approaches and also may need to be retained for certain regions and particular specialties. Second, fee schedules are the building blocks for virtually all the new payment models, most notably bundled episodes. Errors in fee schedules would therefore be carried over into errors in the calculations of the new payments. Third, many prototypical ACOs, which I agree with Chairman Hackbarth is the most promising new delivery model, use relative value units from the Medicare fee schedule as the basis for determining productivity for their member physicians. Again, because fee schedule prices are distorted in relation to resource costs, their assessments can be inaccurate, leading specialists to be valued by the ACOs as more productive than primary care physicians, or one kind of specialist more productive than another kind of specialist simply because of errors in relative value units. As we think about moving to new payment models through the kind of activities that are going on with the Innovation Center at CMS, I would recommend the following immediate agenda for improving Medicare payment to physicians. I would suggest repealing the sustainable growth rate for the reasons that have come up already, especially now that the score is only $138 billion over 10 years. I would not implement a new volume control formula at this time, especially given that volume and intensity of services is remarkably low, at least at this moment, but rather permit CMS to more affirmatively modify prices to try to influence volume and intensity of services. I would consider narrowing or eliminating the in-office ancillary services exception to the Stark self-regulation regulations if the volume of particular services grows unabated. I would revise the definitions of evaluation and management service codes to better describe the work physicians perform, especially for patients with chronic conditions and functional limitations, and also to decrease the current epidemic of upcoding that is taking place. And finally, I would reduce or eliminate the site of service differential, which pays hospitals much more for physician services than are paid to independent practices, separately recognizing the cost of unique hospital obligations and services hospitals uniquely provide. Thank you very much.
Chair, thanks, gentlemen. And Dr. Danberg, you're recognized 5 minutes to summarize your testimony.
Thank you. I want to thank the committee for inviting me here today. I am a senior researcher at the RAND Corporation, and the focus of my work over the past decade has been looking to evaluate pay-for-performance or performance-based payment models. My remarks today address issues related to measuring the performance of physicians under these new payment models that will incentivize or tie payment to performance. And there are a number of issues or measurement issues that I want to call to your attention. Issue number one, existing performance measures are not suitable for newer models that emphasize the delivery of efficient, high-quality care across a continuum of time and healthcare settings. Current measurement focuses on discrete events in single settings of care or silos, rather than looking longitudinally across an entire episode of care. The portfolio of measures that exist today were not developed or envisioned to be used in the types of accountability and payment applications that are emerging, nor is the portfolio necessarily focused on the right measures. Measurement needs to migrate away from a siloed approach, which further perpetuates a lack of coordination, to quality assessment that encompasses all care delivered to patients across an entire episode. Issue number two. When we ask healthcare providers to devote resources to measurement, it is critical that we focus on the important aspects of care that matter most to patients and which providers can most readily influence. Patients care most about outcomes, such as whether a chronic illness like type 2 diabetes was prevented, or for a patient with diabetes, whether the physician and his or her care team helped the patient manage the condition to prevent complications and premature death. Patients also care about whether they can access care when they need it, whether their care is coordinated. They also want to know about how well they're treated in the system and whether their preferences are considered in treatment decisions. And lastly, patients care about the cost of treatment. Regardless of the payment model used, the true north and holy grail of performance-based accountability and payment is measurement of outcomes. Issue number three. Outcome measures are currently lacking in many instances or in a nascent state of development. For example, there are a small number of measures of cost or efficiency, and many are poorly constructed and have not been fully tested for their validity or reliability. Measures that assess change over time and in important intermediate outcomes, such as blood pressure control, and that influence long-term outcomes such as heart attack and stroke do not yet exist. The U.S. could learn from efforts in Great Britain. Since 2009, the United Kingdom's national health system has invited all patients who are having a variety of surgeries to fill in patient-reported outcome questionnaires and has generated comparative statistics to incentivize improvements and help patients understand performance differences across different sites of care. Issue number four. As we transition to a performance dashboard with more emphasis on outcomes, there is work that can be done immediately to strengthen the types of measures that are currently used. For example, we can shift away from focusing on discrete clinical services toward longitudinally measuring the management of a patient. In addition, the HIT infrastructure may enable the creation of new novel measures. For example, EHRs and health information exchange audit trails could be used to construct indirect measures of quality. A specific example is medication reconciliation at hospital discharge. In lieu of a checkbox in the EHR, the audit trail could provide an indirect measure to determine whether the physician accessed the patient medication list and made any modifications prior to discharge. Issue number six. We must focus efforts on strengthening data systems to facilitate delivery of high-quality care by physicians and the construction of performance measures. We cannot expect physicians to coordinate care, avoid duplicative use of services, and manage total cost of care when they are flying blind. I commend to you a paper that was written by a colleague of mine, Eric Schneider. It was actually written in 1999, but is still highly relevant. And this paper lays out a roadmap for an integrated health information framework and identifies 7 features the framework should possess. I won't go into those. They are in my written testimony. Issue number 7, we have to enlist physicians as true partners in the process of defining measures for which they will be held accountable as individuals and more broadly as care teams and systems of care. They have a vitally important role to play in the selection of measures and choosing concepts that will be measured, weighing the scientific evidence, specifying the measures, and assessing the feasibility in practice, and then ultimately endorsing the measures that will be used once developed. Lastly, because much of the current measure development is occurring using federal tax dollars, there's a clear need to coordinate these efforts to better deploy scarce resources and minimize burden on providers. In conclusion, I would like to summarize the actions that could be taken. I think there's more federal leadership that could happen to develop a robust measurement strategy and shift the focus and resources towards a greater emphasis on defining and measuring outcomes. Secondly, support the development of the robust health information framework that is integrated and will allow data sharing across providers and payers. Third, continue efforts to coordinate measurement development within and outside the federal government. Fourth, use a rigorous and transparent and inclusive process to develop measures. And I would just leave you with the thought that in addition to paying providers differentially, it's important to note that public transparency or public reporting can be a powerful incentive. Thank you much. Thank you very much.
Chair thanks the gentlewoman, and that completes the opening statements. The second panel, I'll now begin questioning. Recognize myself 5 minutes for that purpose. Dr. Damberg, we'll start with you. You state that the single most important factor in facilitating or impeding the use of measures was the availability of data to construct performance measures. Can you describe a strategy for bridging this data gap? Is the current HIT legislative and regulatory climate facilitating or impeding this effort? If the latter, what changes do you suggest to remedy the current shortcomings?
While there have been significant investments in the health information structure, I don't think that what is occurring currently is going to help us ultimately with performance measurement. And that is in part because we have not identified the specific data elements, come up with standardized data definitions for those, and I think we are still a significant ways off from data sharing among the different partners, in part because of issues around security, privacy issues, and confidentiality of the data. So I think those are several areas where attention needs to be focused.
Thank you. Ms. Mitchell, can physicians in smaller practices be adequately measured for quality and efficiency? I understand that one problem in terms of measuring smaller size practices is the limitations of small sample sizes. Is there a way to aggregate data from a number of smaller practices to overcome this barrier?
I think it is incredibly important that we ensure that all measures are reliable and valid, and there will be sample size challenges to that. We could also look to patient-reported outcomes, however, functional status measures, patient experience measures. There are measures that can be used for smaller practices that are very relevant to other consumers. But it will be critical that all measures, especially if they're publicly reported or used for payment, are valid and reliable.
Mr. Miller, there are a number of new payment reform models being developed, and as policymakers, we obviously can't incorporate all current and possible future models into one piece of legislation. Yet one lesson from the ACO experience is that if you make the model too prescriptive, it may preclude many providers from participating. Have you given thought as to how you might develop a policy to approve new payment reform models that has the proper balance of detail and flexibility?
Yeah, as I outlined in my testimony, I think that if we have both a top-down and a bottom-up approach, we will be able to get a much richer set of models that are workable much more quickly than we do today. The problem that you saw with the ACO regulations was it was designed to be a one-size-fits-all approach. And so naturally there were a lot of concerns about how well it was going to work in all circumstances, but basically in the end it was one approach. And I think that what you need to distinguish is that it was one approach to payment called the shared savings program. There are many different ways that you could create an accountable care organization, which I think is a very important model to think about. But you don't necessarily, the best model is not to do it through a shared savings program. So, for example, there are many physician groups and IPAs around the country that did not want to participate in that particular program because they felt they were still being paid by fee-for-service with simply a shared savings add-on. But they did want to participate in the Pioneer ACO model because they had the capability to actually accept a risk-adjusted global payment and be able to significantly change care that way. So I think that's an example where if you actually let the providers come forward and define what they are willing and able to do, you will be able to get a different set of models, not in theory that you'd say we have to create a dozen models that maybe nobody wants, but you would actually have people coming forward saying, I know that I can improve care for beneficiaries and I can save money if you change the payment model in the following way.
Thank you, Dr. Berenson. Given the fact that fee-for-service will be around and may even play a prominent role in future payment system, at least for the foreseeable future, how do we deal with spending in the fee-for-service segment of the system? In other words, how do we control for increases in the volume and intensity of services? Will we still need a system of spending targets and possible cuts? And if so, how should the targets be structured?
Yeah, that's a very interesting question. I would point to the results of what happened when the Congress and the Deficit Reduction Act of 2005 correctly, in my opinion, reduced dramatically the spending for advanced imaging services like MRIs and CTs and PET scans. For reasons I don't quite understand, we were actually paying physician practices more than we were paying outpatient departments for those services. As part of the doc fix for that year, those payments were reduced. And what happened in addition to the savings from the prices coming down significantly, volume of those services over the subsequent years has actually moderated. And what I hear anecdotally is a lot of mid-sized practices that really had no business purchasing their own MRI machines and were doing so because of its profitability suddenly decided this was no longer a profitable thing to do. So what I've suggested in my testimony is that the Secretary should have somewhat greater authority to affect prices where there will also affect volume of services. I mean, physicians do respond. I mean, there's this notion that physicians simply respond to price reductions by increasing volume. That's too simplistic a notion. It varies by the service. I think we need to be much more sophisticated about seeing the relationship between price and volume.
Chair thanks, gentlemen, and now yields to the ranking member 5 minutes for question. Ms. Plum.
Thank you, Mr. Chairman. My question is of Dr. Berenson. While there's a consensus regarding the need to move to more value-based payment systems, no one seems to have a clear idea how far or for how we got from our current fee-for-service system, or how we go from our current fee-for-service system to some of the new payment reform models like the accountable care organizations. And as you point out in your written testimony, fee-for-service is actually the foundation for many of these new payment models. So I wanted to ask, if we want to improve the way we pay for fee-for-service, at the same time we're creating incentives for providers to move into new delivery and payment models, what would this transitional period look like?
Well, I pretty much think we are in the transitional period now, even if we can't recognize it, because of all of the experimentation that is now going on. As Mr. Miller pointed out, we have both shared savings ACOs and risk-bearing ACOs that are being tested. We've got various models for bundled episodes being tested. The independence at home, which I think is a very important aspect, which would emphasize home care for frail elderly, medical homes, etc. I think what I said in my testimony is that it's going to take us a number of years to sort it out. I think we should be doing robust experimentation now. I support Harold's notion of having some bottom-up approaches that we would test. I also would endorse Chairman Hackbarth's notion that as we go through this transition, we need to make it we need to put pressure on the fee-for-service reimbursements. And part of what I suggested is in shifting more reimbursement to primary care away from tests and procedures, we would be putting that pressure. Ultimately, we want to be in a place where physicians find it's in their own interest to want to move into a new organizational structure or accept new payments rather than stay in fee-for-service. I think most docs know that sort of unfettered fee-for-service with no incentives for collaboration and coordination probably is not the right payment model. So I think we are in the transition now, and happily, the volume and intensity of services and therefore CBO's estimates of future spending in Medicare has moderated significantly. So I think we can take the time to really do what's necessary to understand where we want to go at some point. I don't know if that's 5 years from now, 7 years from now. We would have to, at least on a regional basis, possibly on a national basis, say we now have enough confidence in an alternative payment model that we are really going to expect doctors to move to that, with the fee-for-service as sort of a legacy system for those who can't make the adjustment.
All right, thanks. I'm going to try to get one more question in here for you and also for Ms. Mitchell. And, Mr. Chairman, for this purpose, I wanted to ask unanimous consent to introduce in the record this letter from the National Partnerships for Women and Families, which I think you have. Okay.
Without objection, so ordered.
Thank you, Mr. Chairman. There's been a significant movement over the past decade towards the establishment of multi-stakeholder consensus processes for healthcare quality and performance measurement. And Mr. Chairman, this letter references the SGR proposal being circulated by the Republican Ways and Means as well as Energy and Commerce staff. And in that letter, the National Partnership raises a number of concerns about the role medical specialty societies are being given to develop and select quality and performance measures that would be the basis of their payment, and the apparent exclusion of other stakeholders, including consumers. They're concerned that this appears to reverse the positive trend over a number of years towards including a broader group of stakeholders in the process. So, Dr. Berenson and Ms. Mitchell, over recent years, there's been a lot of work developing consensus processes for development of quality and performance measures. What are your views regarding the appropriate roles for physicians, and how important is it to have consumers and other stakeholders involved in this process? And you've got 28 minutes left.
28 seconds. I'll be very quick. I'm a believer in multi-stakeholder participation, but ultimately I think Dr. Danberg would agree that the measures that we come up with need to be valid and reliable, and need to pass sort of scientific muster from an organization like the National Quality Forum. So I would have consumers at the table, and I wouldn't simply defer to what the specialty societies would prefer in terms of how they would be measured.
Ms. Mitchell, quickly.
Well, having run a multi-stakeholder process for over a decade in Maine to include physicians, unions, employers, and consumers at the table to select measures, I can tell you it is possible, and it's very important. We have measurements now available that would not be if it were just for one stakeholder group. So it is challenging, but it is extremely important, and I think it absolutely can be done, and I think the National Quality Forum and their multi-stakeholder approach is very important.
Thank you. Thank you, Mr. Chairman.
Chair thanks the gentleman, and now recognize the Vice Chairman, Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. I want to thank our panelists for sticking with us through what has been a long but important hearing. Dr. Berenson, I was hoping you could help me with a couple of the points that you made, specifically point 3 and point 5. Point 3 being the in-office ancillary services, where you said you would target those. I presume that means reduce those. You would target those for fee reductions?
Right now, I would want to see whether the reason that there is abuse in the in-office ancillary exception. We now have physicians like dermatologists and gastroenterologists who used to send their specimens out to an independent pathology lab are now doing those in-house under this exception. But at least some articles have described, instead of doing the specimen to confirm that the biopsy is not malignant, they're now doing multiple slices getting multiple payments, clearly abusing the opportunity to do those services themselves. Imaging has been a major concern about the in-office exception with practices that are buying machines and then supplying them. So what we learned with the imaging example is if we reduce the over-generous payment, we reduce the incentive to do some of these services. So that's what I had in mind.
I appreciate you paying attention to when we worked on the Deficit Reduction Act in 2005, because that was the work of this committee that led to that. But then, point 5, the counterproductive nature of the correction of misvalued services, and this one based on the site of service differential, which really has led to almost the destruction of office-based cardiology in favor of hospital-based cardiology. And we literally watched that happen over the last 3 or 4 years, and I really think it's to the detriment of patient service. But nobody's getting a better deal because those services are now performed in the hospital. In fact, it was probably a better deal for the patient, regardless of the pricing structure. It was a better deal for the patient to be seen in the cardiologist's office, have the test done, have it read and treatment rendered and judgment rendered at that point, rather than multiple trips back and forth to the hospital to have the procedure done and then the consultation with the cardiologist. Can you speak to that?
Yes. Now, there may be reasons for hospitals to employ physicians if they have a commitment to become an integrated delivery system and potentially an ACO. But a good reason is not to take advantage of the provider-based payments that provide, I would call, windfall revenues for the hospital, raises the cost to Medicare, raises the cost-sharing obligations of beneficiaries, does, as you point out, sometimes lead to greater inconvenience. The hospitals say that they do have obligations that practices don't have. Standby capacity, 24/7 standby capacity, running emergency departments, seeing uninsured. I want to recognize those costs, but I want to recognize those costs in services, inpatient services or ED services, not in an outpatient service that can be done just as well at the same, roughly the same cost in a doctor's office. So I agree with you. I think it is unfortunate that we have had a huge migration of cardiologists out of office to become hospital employees, not to be providing higher quality or efficiency, but to take advantage of this site of service payment anomaly.
Well, we've come to an unfortunate place in our country where it is prohibited for a doctor to own a hospital, but hospitals can own doctors. And that, to me, has put entirely the wrong incentives out there.
Well, we do have some multi-specialty group practices that own the hospital.
But under the Affordable Care Act, as far as developing a new facility, that can't happen.
Yeah.
Which really seems unfortunate because of the fact that you and I hold a professional degree. We are precluded from entering a business practice.
The issues there relate to whether the physician-owned hospitals were in a position to cherry-pick the patients, and MedPAC and others provided reports. It's a difficult issue.
Yeah, and it's not as clear-cut as that. I mean, a very clear article on that written in Health Affairs in March of 2008 by me, which said the most valuable thing I have is my time, and if I've got an uninsured patient and I can take care of them at an outpatient surgery site, and my time is valued by that outpatient surgery site, I'm actually ahead, even though I didn't make any money that day, and the facility didn't make any money. It didn't cost me the vast investment of time that it would cost me to wait in line behind a hospital surgery schedule. Separate point. I didn't mean to bring that up, but you forced me. Dr. Danberg, let me ask you a quick question. You just referenced that patients care about the cost of care. Did I hear you right when you said that?
That's correct.
Well, now the Commonwealth folks came out just early this month and said that activated patients cared about the cost of their care. And, well, I don't really want to get into the nuances of what an activated patient is. Certainly that patient who has a financial interest health savings account owner, for example, in my estimation, would be an activated patient. So that would be a patient who cared about the cost of care. In my experience as a physician, when someone came in and I recommended a test or procedure, the next question was, doctor, is it really necessary? Doctor, is it safe? The next question was, doctor, does my insurance cover it? If the answer to that question was yes, there was very little other curiosity about anything else. So am I wrong in thinking that way?
Let me give you a little story from California, from where I hail. So a colleague...
Well, let's do real life, not California.
Well, I think the example holds the rest of the country. So someone that I know needed to have cataract surgery, and he looked within a particular zip code and found variation in terms of the amount of money it would cost to do this procedure, ranging from $3,500 to $11,000. And given that he is financially at risk for a portion of that
Correct.
payment, that starts to have significant implications.
Hence the activated patient concept.
Right. And I think what you see on the private sector side now is movement toward what's called reference-based pricing. And so what health plans are doing on behalf of employers is going out and doing that work to try to understand these pricing differentials, make that available to consumers.
Yeah,
and help
probably
them
better if the
understand.
patient's involved in that, not the employer. And we can perhaps I'll generate a question for a written question for the record that I'll ask you on that. Thank you.
The chair recognizes Mr. Sarbanes.
Thank you, Mr. Chairman. Dr. Berenson, when do you think we realized, had this epiphany, or has it been a slow process of gaining realization that we needed to start moving from this fee-for-service system to something different? I mean, how long have we been kind of trapped in this old system, even though we've been able to see that we got to move in a different direction?
Well, what's interesting is, in fact, 2 decades ago, it didn't have the label value-based payment, but the system, when I was practicing medicine in the 80s and into the 90s, we had global payments as a common payment method. The U.S. healthcare model that HMOs were paying doctors on the East Coast basically had pay-for-performance, but with shared savings. 25% of my capitation was withheld, and I got it back only if the costs of all of my patients, all of their costs, were below a certain amount. So, in fact, we have been doing these new payment models. I think it came a cropper because of the managed care backlash and some problems. We then reverted back, I think, to the early part of the last decade to sort of traditional fee-for-service, traditional freedom of choice. And then once we got over that backlash and began to look again and said costs are really going up, there were a couple of seminal articles suggesting that quality wasn't terrific. I think we came back
But I guess
to those models.
I mean, one difference now is that the better management that you're trying to incentivize is going into the hands of the providers more. At least that's the hope and expectation here.
Well, I think that's right, although I would point to the California delegated capitation model has been alive and reasonably well. It had problems in the 90s for over 2 decades where providers, doctors mostly in control. That is what we are now trying to do in Medicare with ACOs, and I think that is a good idea. What is new, I think, in the last couple of decades is we have much better data systems now to track performance, and we actually do have the beginnings of quality measurement, beginning to focus on outcomes, which we did not have. One of the reasons for the managed care backlash was the perception that at-risk medical groups had an incentive to stint on care, and patients, members of health plans, were concerned that they would get shortchanged. We now have some ability to monitor that that's not going on. So I think we're in a better position to do what was tried a couple of decades ago.
Let me ask you this question. If you could, obviously this transition is going to be a heavy lift, and there's going to have to be a lot of research behind it in terms of changing these RVUs and coming up with new codes and everything. But if we could snap our fingers and know tomorrow what that new methodology would be based on all of the research and everything. So you said, we know what it is, now we have to deploy it. How long do you think it's going to take for that phase, just to kind of, as a practical matter, implement something if you already knew what it was today?
Oh, I see. I guess one of the decisions, there are a couple of sort of core decisions that would have to be made. One is, do we put in a payment system nationally that everybody's going to participate in, or can we roll this out by region as different regions demonstrate an ability to move? If we have the flexibility to do the latter, I think then it's much easier to do. Some states and areas within states are really ready, I would argue, for really new payment models and new delivery. Other places are not. So that's one issue. Another is whether the threshold question of whether we are providing options for physicians to opt into, or whether we're going to make it mandatory. I think the different payment models probably call for a different answer to that one. It may be that not, I mean, in fact, I don't think ACO should be required to have every physician in the community. They would have credentialing criteria as to who really meets the expectations of the ACO, and maybe some docs would not be in. Other payment models, like a bundled episode, I have trouble imagining that that would be sort of voluntary. I think if we find that it works, we're going to implement it. I don't know, 3 to 5 years would be my guess. If we knew today that this is where we wanted to go, I would say something like 3 to 5 years to put it in. I would much prefer to do it on a regional rollout basis than on a national all at once.
That's helpful. Thank you. I yield back.
Thank you, Mr. Sarbanes. The chair yields to Mr. Hall.
Mr. Chairman, thank you. I've been in another meeting, and I don't know what questions have been asked, but I understand you usually allow us to write questions to them and ask them to answer them at a reasonable time, correct. 2 or 3 weeks.
Correct.
Thank you, Mr. Chairman.
Okay. The chair yields to Dr. Gingrey.
Mr. Chairman, thank you. I also have had to step out, and I apologize for that. But in the last panel, Mr. Hackbarth, I asked him about burdens to real reform, specifically IPAB. And I look to engage this panel on the same question. What administrative and legislative burdens are in place today? IPAB, obviously, a legislative burden, as I see it, hinder the development of lasting reform, and how can we proactively work to remove these barriers to achieve better patient outcomes at a lower cost? Let me start from right to left. Dr. Dahlberg, is it? Danberg, would you start? And then each one of you, if you respond to that in regard to specifically IPAB, I want you to address that.
I'm not sure I'm qualified to talk about APAC, but in terms of other areas where I think federal regulations are getting in the way, I do think, going back to the health information infrastructure, issues around privacy, security, data sharing, having standardized data elements, including a patient identifier, are really handicapping our ability to measure patient care across providers longitudinally in the system.
Yes.
Well, I have, I'm not quite sure I agree with you on IPAB. I agree to the extent that I don't think we need 15.
You heard my conversation with Mr. Hackbarth on the first panel.
Right. I don't think we need 15 experts from the outside who bring some special wisdom. But the concept of having the secretary have the authority to have, if it's essentially putting Medicare on a budget and giving somebody the authority to recommend how to, where to cut mostly payment rates to accommodate those limits, for some action, and I think more discrete action than just across-the-board arbitrary cuts, which will occur if a sequester goes in, and which would have occurred under an SGR implementation. Just we're going to whack all prices equally. Part of my testimony was to make the point that I believe there are areas in the physician fee schedule, to take that specific example, where the prices far exceed the resource costs of production. I think there's an opportunity to do that. I think as a matter of its normal business, CMS should be doing that. But if, in fact, we had to live within a budget limitation, I think it's not unreasonable that the Secretary would have the authority to...
Ms. Miller, I thank you. I didn't mean to cut you off, but Ms. Miller, did you have a response on that? Mitchell, I'm sorry. Ms. Mitchell, thank you.
Thank you. I am also not prepared to comment on IPAP, but I will tell you that what we...
Hold your mic a little closer if you don't mind.
Well, what we need most, I think, on the ground are resources to actually support a data and measurement infrastructure and to support multi-stakeholder work, and the easy ability to integrate multi-payer, all-payer claims data with clinical data to give that feedback to physicians and to share that information with...
Well, I think you kind of avoided my question in regard to IPAP. I'll let Mr. Miller have a shot at it.
Well, I will not avoid your question, Dr. Gangry. I think the fundamental fact that you have to keep in mind is that only 17% of Medicare spending actually goes to physicians. You could cut physician spending by 27%, as you was proposed to do in the SGR, and you would only save a few percent for Medicare. But if you can actually have the physicians helping you save the other 83%, you can save an extraordinary amount of money in Medicare. And that is where I talked about at the beginning, is all of those preventable hospitalizations, unnecessary procedures and tests can be saved. And I think the problem is we continue to try to fix a broken system by trying to Congress has two choices. If spending is controlled by utilization times price, then you say, okay, we can either take things away from Medicare beneficiaries, we don't want to do that, or somehow we're going to cut the prices, the amount that we pay to providers. Neither of those is a desirable approach. But if you can actually change the way that you pay physicians and ask them to come forward and say, where can we save money without hurting patients, I think you can find tremendous opportunities. When I go around and talk around the country, I give talks to physicians, and when I ask them, I say, can you tell me where you can save money in Medicare? And I brought along examples. They all give me examples. I have pages and pages of examples from Maine, from Virginia, from Seattle, telling me, and I could give you examples from other states, where physicians tell me all the places where there are opportunities to be able to save money. And then I say, and why aren't we taking advantage of those now? And they describe the barriers in the current payment system. So there are physicians I have found all over the country who would actually come forward and be able to significantly reduce Medicare spending if we give them the opportunity to do that. We are not going to achieve that by cutting their payment rates. If you thought that a price of an airline ticket was too high, would you solve that by cutting the salary for the pilot? I don't think so.
Thank you, and thank you, Mr. Chairman, for your patience.
The chair recognizes Mr. Griffith.
Thank you, Mr. Chairman. I like that point, Mr. Miller, that you made about bringing forward the physicians, because oftentimes the people in the system can tell you how to solve those problems. And so I look forward to working on that as one of the solutions. I'm going to switch to you, Ms. Mitchell. You describe geographic disparities in quality and cost of care within your own state of Maine, with vast potential for qualitative gains and cost savings if best practices are widely adopted. And I guess I'm curious, how do you describe, or how would you suggest that we achieve this geographic parity, and keeping in mind that I'm also looking not just at specialties, but the fact that I have a large rural district with lots of small communities. Some of my counties, have less than the 5,000 people necessary to do one of those new bundling formats that we were talking about with the previous speaker.
Well, I think the good news is that you don't need a lot of people to do this. Maine is equally rural, as I'm sure you know. Yep. And what we were able to do was bring physicians, employers, patients together to look at the data and really look at the variation. We found opportunities to reduce, for instance, cardiac spending by $35 million just by getting to current best practice levels within the state. This is not unattainable. It's actually being done. So when you facilitate not only that information being shared, but then bringing those best practices to the other areas, there is a lot of learning. You need technical support, you need information, you need feedback loops. All of those can be done at the local level. We also found massive variation in early induction. And just by sharing that data statewide, we saw up to a 20% reduction in those rates because they understood that that needed to change and that what best practice targets were. So sharing information in and of itself is a very powerful practice. It does not require an ACO to do that. It requires engagement and data of the with the physicians.
Which would be an amplification of what Mr. Miller was saying.
Absolutely.
Okay. And Mr. Miller, how do you encourage the physician buy-in, particularly in rural areas where you may not have sufficient numbers of docs to begin with?
Well, I think there's two ways. First of all, you have to spend the time to help physicians understand the model and to be able to get the data that they need to understand how this will work for them. I've found when I have done programs, and I did a program last fall for the Medical Society of Virginia, we had physicians from all over the state came in and spent a day actually working through the payment models, episode payments, comprehensive care payments for chronic disease. And after they had a chance to work through them, we took a little straw poll at the end and said, so which model would you rather be in, the current model or this model? And almost unanimously they said the new model. But then the question is, how will that work for me? Because it does come down to what's the price. And nobody actually knows today. They don't have the data to be able to do that. So if we can get them the data, and it's not just data, it's actually turning it into information. So simply handing a physician, 7 multi-million claim record files from Medicare is not the answer. They're going to need help, and they need to get that help from some trusted local entity. The kind of thing that Elizabeth Mitchell runs in Maine is a place where physicians have a seat at the table and have the access to technical assistance that they trust. And then some assistance in being able to transform the way they deliver care. And I think that if you then go to a rural area and you say, well, how will this work here? And what tweaks do we need to be able to make in that model to make sure that it does work here, given that patients may have longer travel time, et cetera. But the flexibility of the model means that you can actually design a different system in a different place. You might say in a rural area we need to be able to do more telemedicine to be able to try to bring resources into unpopulated areas, then we can do something different in an urban area. So I think that's the real advantage of these flexible payment models, is they would actually give physicians the flexibility to design different care delivery systems that work in different communities.
Well, I appreciate that, and I would have to tell you that I am not surprised that if you went to talk with the Medical Society of Virginia that you got some interesting ideas. I served in the state legislature for 17 years and worked with them on a regular basis on a number of issues, and it's a good group of people who are out to solve problems. They are looking out for their territory, but they're also out to solve problems, and they've always been that way. I appreciate it very much, and I yield back, Mr. Chairman.
Thank you, Mr. Griffith, and the chair recognizes Ms. Capps.
Thank you, Mr. Chairman. I'm going to point my first question to Ms. Mitchell. Maybe there's time to have others weigh in on it because this topic has come up today, but with the previous person on the panel. Delivering high-value patient or person-centered health care seems to be moving away from the traditional physician-based model to one involving a health care team, including both physicians and non-physician providers. Arguably, too much of our discussion tends to be focused on doctors on SGR topics and not enough on the other professionals, and we know how critical they are to achieving high-value care. As we debate what comes next after SGR, I think we're all in agreement that we need to focus on what will come after it. Their voices, the voices of these other providers, I believe are critical to ensuring an efficient and effective model of care, or models of care, that take care of the whole person, with that being our focus. So my question is, and I can see others nodding, so if you could go quickly and each make a short response to this, I'd like to have you all be on the record on this topic if possible. So the question, how do we ensure that non-physician providers are appropriately engaged and appropriately valued as we move forward with new delivery and payment systems? I'll start with you, Ms. Mitchell, because I had directed, and then with Mr. Miller, Mr. Berenson, and Dr. Danberg, if you'd like to comment too.
I think one of the most promising developments in any of these new models is the patient-centered medical home, as I'm sure you
big champion of it.
That is absolutely about team-based care.
In fact, some have said it should not be a medical home, it should be a health home.
I like that.
Because that's positive.
And we are doing both in Maine. And I will say that one of the most effective members of that team is the care manager based in the practice, not a physician, usually a nurse, but another key team member who actually makes sure care is coordinated and managed. We are also
over time, you mean?
Over time, absolutely, and in the community. We are also implementing community care teams for high needs patients. We work with Dr. Brenner on hotspotting. Who are these people? What supports do they need? Early anecdotal evidence, well, actually data-driven evidence, is showing 40% reductions in some of their spend if they get the right care at the right time. These are not physicians. These are community-based.
I can only imagine there might be some resistance from some. So let me hear a quick comment from Mr. Miller, if you'd like.
Congresswoman, I ran a project in Pittsburgh to try to reduce readmissions for chronic disease patients, and we made a variety of changes in the hospital and physician practices, but the most critical change by far was we hired a nurse who could actually follow the patients and go and make home visits to them, and we had a 44% reduction in chronic disease readmissions to the hospital.
So glad we're getting this on the record.
But the only way we were able to actually hire those nurses is we got a grant from a local foundation to pay for them. And at the end of the project, we had to lay off one of the nurses because no health plan would pay for it. Medicare does not pay for it. We were fortunate enough that in one case, the hospital was willing to pick up that nurse to be able to continue to work with the PCPs and the patients.
It surely does indicate
that is the issue.
to me.
The flexibility of the models. I think when I talk to physicians all over the country, they would love to be able to hire a nurse to be able to do this work. They are not reimbursed for it.
Mr. Chairman, in response to this, I surely hope this is a topic that we can continue to get engaged in. I don't pretend to have the answers. And just because I'm a nurse, and certainly do appreciate your comment, Mr. Miller, it isn't just about nurses. And you being a doctor, I know can understand that it is really about who we're focusing on in this kind of model. Dr.
But I would also just add quickly, the nurse worked with the physician.
Of course.
The nurse did not work for a health plan, was not working in some disconnected
fashion.
She was they were working as part of a team with the physicians,
okay.
But it added that critical element that the physicians could not do on their own.
And reduce the cost that much. Wow.
Three quick points. One is that fee-for-service is really a problem because somebody has to make a rule as to is a nurse practitioner working incident to or independently.
Exactly.
And they're arbitrary and they don't work.
There's a lot to work at. That's why this is going to take, even from us, and there are other people who will want to weigh in, a lot of discussion, many hearings, hopefully.
Second, I've just completed doing a number of interviews around advanced primary care. Some people prefer that term to either health home or medical home. There was a focus group that said, a woman said, let's see, medical home, funeral home, is that what you're talking about? Yeah, nursing home, funeral home?
Gotcha.
So there's a labeling issue I don't think we have to get into. But the docs all said the real advantage that they have gotten as part of the multi-payer advanced primary care was being able to hire a care manager nurse to work with the really frail seniors and keep them out of the hospital. And the final thing, very simply, is if we have a global payment to an organization, they can decide who the personnel should be. And I think nurses and other non-physicians will do very well in that calculation. It's not somebody in Baltimore or Washington telling them what their mix of staffing would be.
And I might even say maybe that person is the right one to decide it, but there might be somebody else too, but certainly local rather than some other place. And I know I'm out of time, but because I think I might be the last person to ask questions, would you mind? I'd just love to get the fourth viewpoint on this. Thank you.
I would echo Mr. Miller's comments. One of the things that I've seen in California, there are the Center for Medicare and Medicaid Services Innovation grants going on. And
yes.
Some of those involve the use of nurse case managers and other personnel. And one of the things, those models are supposed to become self-sustaining over time.
That's the challenge.
But I think the focus right now in those different evaluation or those projects is, is Medicare going to change its payment policy such that we can continue to hire these personnel beyond the life of this project?
That might be the very next subject for a hearing. Not that it would be my decision, but it might be a suggestion that is coming apparently from this team. So I yield back my time. Thank you.
Dr. Gingrey has a quick question or comment.
Mr. Chairman, a unanimous consent request to briefly ask of Mr. Miller. At the end of my line of questioning, you had indicated there were some barriers to these multitude of ideas that you showed us in your legal papers in regard to physicians not being able to share that information that you've gleaned. If you would submit to the committee maybe a list of some of those impediments to them being able to share that information, because I think it would be very, very helpful to us as we go forward.
Well, the barriers are for them to actually implement the changes that would be necessary to save, but I would be happy to share those. I think you would find it very insightful to see the range of different opportunities for savings that physicians identify. But it all comes back in many cases to the payment system that does not actually allow that to happen. It's not an issue of incentives. It's the fact that there are genuine barriers and restrictions, like the fact that a nurse does not get paid for today. That is a barrier.
Yeah, and so within a week or two, if you could do that, I would appreciate it. Mr. Chairman, thank you very much.
Okay, thank you. The chair recognizes Mr. Bill Rockus.
Mr. Chairman, I appreciate it very much, and I want to thank Chairman Pitts and Chairman Upton for giving me the opportunity to serve on this very important committee. I have a couple questions. First one would be for Mr. Miller, and I know you touched on this somewhat, but discuss the importance of defining specific outcome-based quality measures. What strategies do you propose to determine these measures?
You're directing that to me?
Yes.
So I think that, as the committee has recommended, I think that physicians are in the first best position to be able to identify what some of those outcome measures should be. I think then there should be a multi-stakeholder process for looking at that and saying, are those the right things to ask consumers whether that deals with the kind of things that they are looking at. I do think that what we have to do is to start moving more to outcome measures, and particularly to patient-reported outcome measures. Dr. Danberg talked about that in her testimony. But in order to be able to do that, you have to have some infrastructure in a local community to be able to actually survey the consumers and ask them. And that's where having a trusted entity, a multi-stakeholder collaborative in the community that can actually do that work, to be able to do the surveying of the patients, to be able to do it reliably, and then be able to report that in an accurate and objective fashion, I think is critical to being able to assure everybody that, in fact, the care is improving and that you're getting the value for what you're paying for.
Thank you very much. Next question for Ms. Mitchell. Can you discuss the opportunities for better care and financial savings through use of the community care teams and the hotspotting that you mentioned in your testimony? Is this a strategy that you foresee being scalable to different community demographics, such as because rural, urban, and suburban, et cetera?
Certainly, I think it's imminently scalable, and it's probably not even that expensive, because these are teams of nurses or even lay people at some times. But what we are finding is the key drivers for the heavy utilization are often mental health issues and substance abuse issues and other social determinants of health. So to be in the community and understand what the barriers are to these people actually getting better and not having to return to the hospital over and over again, it's not high tech. It's really working with the individuals, and I think it's not only scalable, but really urgent to do exactly that.
Very good. Thank you. Thank you, Mr. Chairman. I yield back the balance of my time.
Chair recognizes Mr. Green.
Thank you, Mr. Chairman. And again, I want to thank our entire panel for being here today. And some of you may have heard my questions earlier of our first panel. And I'd like to see if both from Ms. Mitchell and Dr. Bernson, if there would be anything different. How do we measure the quality accurately in a way that avoids a one-size-fits-all approach and put the patients first and avoids the endless complexity that could develop if we build too much flexibility into a system?
Thank you. I think you have heard repeatedly, and I certainly concur, that outcome measures are the holy grail. But also, we really need to think about functional status measures. Is someone healthy? Can they participate in their daily life effectively? So functional status measurement absolutely needs to be further developed and disseminated. Patients really care about patient experience, and that's somewhat different than patient satisfaction. It's really, did they get the care they needed? Did they understand their role in continuing to manage their own health? So patient experience is equally important. I really have to say, though, that cost and resource use are equally important. We need to understand are resources being used effectively for patients and for communities? So I think it is a combination of all of those different types of measures that really get a view at an accountable system.
Dr. Burns?
I'd make a different point, which was in my testimony. I was emphasizing that there are some major gaps in what we measure and what I would argue that we can potentially measure in terms of at the individual physician level of what we want to measure. So, for example, for a surgeon, I think what we really care about is technical skill and judgment in deciding when a patient needs to go to the OR and what procedure they might need. I mean, we don't have measures of that, so what we do measure is relatively small stuff. Did the hospital give antibiotic prophylaxis before surgery? I think we have to recognize that there are some very important things we can't measure. We will get a much better job if we move towards outcomes rather than just relying on these kinds of processes. And the other point I would make, I think in agreement with everybody here, is the one thing that is ubiquitous in all physicians or hospitals' experience is the patient's experience with care. And I think we can be, while we have these large gaps in what we can measure and while we're working on an outcomes agenda, I think patient-reported outcomes and patient experience is really the one thing that applies across the whole system, and that's where I would be putting my emphasis at this point.
It seems like, I know we've discussed this for a number of years, and we have some almost laboratories in certain areas, whether it be in Pennsylvania, where our chair of the subcommittee is from, and Geisinger and Kaiser Permanente in California. Are we actually learning now from their experiences on moving to that outcome-based in some of those? I know there are other ones in the country. Those are the two that come to mind. Seeing some of those indicators that we would need to do, what Congress needs to do, to put in the law so we could do it with that experience we're hearing. Is that positive or negative? Or?
Well, I would just say, if you mentioned Geisinger, for example, there's a perfect example of a provider organization that agreed to take accountability for outcomes and said that we will have a single price for all the costs of care associated with a particular procedure or condition, including maternity care. What they did was they developed themselves a whole series of quality measures internally to look at, but they controlled them because they were accountable for the outcome. It wasn't some external entity saying, here's what you should do to make the cardiac bypass surgery work well. And because they were in control of them, they could manage them. They could decide which of them did not work and did work and adapt them. The problem that we have, and one of my great fears, is that when we start to create more and more and more quality measures, particularly process measures that are imposed by payers or by Medicare or whatever as part of pay-for-performance, we are locking in the old style of practice. And in fact, what we want to do is to be able to unleash the creativity and the judgment of physicians to be able to say, if it isn't working, what do we need to change to be able to make it better? People talk about evidence-based medicine, but where did the evidence come from in the first place? But some physician who actually figured out how to be able to make it work. And we shouldn't then say that whatever they discovered 10 years ago is as best it's ever going to be. We should say, if you can continue to improve, and I think that's what these different kind of payment models will allow, is the flexibility to actually continue to improve rather than being locked into the old way of doing things.
Okay. Thank you, Mr. Chairman.
Thank you. The chair now recognizes himself. I have incredibly enjoyed this testimony. Mr. Miller, we are intellectual brothers from a different mother. And so I just want to tell you, and each of you...
I'm delighted to hear that.
Each of you has a standing invitation to call me for dinner, and I'll treat, because I'd just love to pick your brain. So, but let me go a little bit. I couldn't find it in your testimony, but I think I recall you saying that these models that we should allow to bubble up should also include specialty societies. Frankly, the paradigm most speak of is primary care. That's a little bit threatening, though, to the neurosurgeon that thinks that she may be doing a great job but may be iced out because of whatever reason. How, in your thinking, could a specialty society evolve into one of these models?
Well, I'm not sure.
And a specialty society.
I would not say that the primary care should be threatening. I think that the issue is that we are, in fact, putting excessive burden on primary care physicians to somehow fix everything about the cost and quality of health care. when we do these models. I have talked to specialty physicians all over the country in a variety of different specialties, and these examples that I cited have examples from every specialty: gastroenterology, infectious disease.
So let me ask you, if there's going to be a global, you had a nice firm for a global payment for a population, then that almost implies that there's got to be somebody.
I think you're jumping too quickly to saying it's only global payment. My point is, in fact, that I think that there should be different payment models that are specialty specific. So if a gastroenterologist says, I can do a better job of managing inflammatory bowel disease, they should be able to do that if they can improve quality and reduce costs.
And they would in turn contract with either the primary care or with someone.
With whoever would be appropriate. I mean, in many cases, I think gastroenterologists, to take the inflammatory bowel disease example, would be ones they would actually serve as the medical home for those patients because that is such a dominant condition.
Yes, I understand that.
Then what you can do is you can...
Let me pause you for a second because I get that, and you may know I'm a gastroenterologist, so you just hit my sweet spot. So next. Now, Dr. Domberg, you mentioned that there is difficulty coming up with meaningful measures. And both you and Mr. Miller comment on how we are currently measuring processes. But it really seems to me that if you give somebody a global payment, as an example, and they know that in order to improve outcomes and increase profit, they should reduce hospitalizations, as long as you have the kind of quality measures Dr. Berenson spoke of, which keeps them from skimping on care, almost by judging them on that outcome, you are going to get a better product. Does that make sense? Will it take care of itself if we go to the correct payment model?
So my remarks, if you look at my longer testimony, really focus on getting to a set of defined outcome measures, that should be the focus to the extent that you're going to devise a new system of payment for providers that holds some portion of it at risk for performance on a set of indicators. Outcome measures are going to be more stable over time, but it is going to be critical to get physicians at the table to define what those outcome measures are.
I accept that, but on the other hand, if you know that the hemodialysis patient who doesn't crash into dialysis but glide past down, who gets their thrombosis removed as an outpatient as opposed to an inpatient, we could go through other examples, is actually going to have better care and it's going to be lower cost care, as long as we know that they're actually getting dialyzed, they're not skimping, and we have some audit, Dr. Berenson again mentioned this, it seems as if by judging that outcome, you almost take care of the processes.
I think that that's right, because what you're letting the system do is self-correct. So one of the things that I've observed under the Medicare Advantage program, because they're getting ready for 2015, the quality bonus payments that are kicking in that will only reward health plans that have 4 or 5 stars. There is a huge amount of what I'm calling anticipatory behavior going on, where the health plans and the physician groups are working very proactively to ensure
to get their stars up.
Exactly. And so
I get that. Can I move on?
To that North Star.
Yeah.
They will work toward it.
Now, let me ask Miller and Mitchell, if you will. You mentioned this regional coordinating thing, which really seems really good, but it's going to take, y'all took a lot of effort to put that together. I keep on thinking that you have this MA set of systems, and the MA plans actually have all this data. They know how to market, they know how to bill, they know how to coordinate care, and they know for what bundle of care somebody's going to give you a certain quality and cost. It almost seems like you could allow that small group to contract with them to provide those services, not in a traditional MA plan, but rather mainly as a management program, if you will, a data management program, and perhaps a provider of reinsurance. Any thoughts on that?
I think what you will see increasingly in the future is a complete flip. You will not have doctors being subcontractors to health plans, but health plans being subcontractors to physicians to provide the services that they need. In fact, if you look around the country, there's only 11 Medicare Advantage plans in the country that are 5-star. 10 of them are provider-owned. And most of the 4.5-star plans are also provider-owned. So I think there's that opportunity to do that. And I would say you should, the Louisiana Healthcare Quality Forum is a multi-stakeholder collaborative in Louisiana that's working on trying to do this. What all the collaboratives have is the problem of getting any recognition from the federal government that they exist and to be able to give them the support to be able to work with physicians.
Now, but if you do the subcontracting with the MA plan, it almost seems as if you supplant the need for a public entity, but rather you have a private entity that can then take that role.
You could conceivably have a situation in the future where you have provider-driven plans selling policies to patients, and you would not have traditional Medicare fee-for-service at all anymore.
Yeah. Okay. Y'all have been very helpful. Let me dig out and say what I'm supposed to say at the very end. This is it? Okay. Thank you all. At this time, I'd like to ask unanimous consent to have a statement from the American Medical Association and the American College of Physicians included in the record. Without objection, so ordered. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond to the questions promptly. Members should submit their questions by the close of business on Thursday, February 28th. Without objection, the subcommittee is adjourned. Thank you again.